3, 2, 1. Please start, sir. We are live.
So, good evening, everyone. It's a great pleasure to welcome you all for second day Lung Cancer Conclave, Revisit WCLC and ESMO. So, for welcome note, I would like to invite Dr. Piyush Bajpayee, sir. Sir is a HOD and consultant, Medical Oncology, Manipal Hospital, Delhi. Welcome, sir. Please start.
So good evening, everyone, and the second day of the lung cancer conclave. So we had a very exciting day one. We discussed a lot of perspectives from local therapy, the radiation and the surgical. So yesterday was, again, immunotherapy was a common keyword being used. Here again, day two, we are going to focus on both the early as well as the advanced lung cancer, but the systemic therapy would be the mainstay or the mainstay of discussion. So to set the ball rolling, and before I say that, so I would request every speaker to please stick to the timeline so that we can actually take meaningful questions and deliberations. So it's my honor and privilege to actually invite the chairperson. So Dr. Shyam Agarwal, sir, welcome, sir. Sir is the chairman and head of Department of Oncology at Sir Gangaram Hospital, New Delhi. So, sir, I hand over the further proceedings to you.
Right. So thank you very much, Piyush, and congratulations for organizing this meeting. I think today we are focusing on lung cancer, the WCLC and the ESMO updates. And I think newer agents are being brought into kind of daily practice. So things are really evolving in a very rapid fashion in the area of non-small cell lung cancer. So we have three abstracts from ESMO, which are going to be, debated or presented. So I think the first one is on the RET1 inhibitor, sulfatinib, and the Libretto 431 study, which will be presented by Dr. Kaushal Kalra. He is the consultant medical oncologist at Safdarjung Hospital and VMMC. So the time allotted is about 7 minutes. So you will request Dr. Kaushal to start and finish in time. Thank you. Dr. Kaushal is there?
Yes, sir, I'm here. Please share my slides.
Just a minute, sir. I will share.
So is it visible?
Go ahead.
It's not visible to me. Yes, it's visible. Yeah. So is it visible to all?
Yes, yes.
Yes, sir.
Yeah. So today we will discuss about the Libretto 431 trial. It's a randomized phase 3 trial of the first-line sulfatinib versus chemotherapy plus pembrolizumab in the RET fusion positive non-small cell lung cancer and adenocarcinoma. Yeah, next slide. So coming to the background, as all of us know, this thing, first-line platinum-based chemotherapy along with the pembrolizumab is the established standard of care for the patient in NSCLC without any EGFR or ALK mutations. In Keynote 189, overall response rate was 48% and median PFS was 9 months. In the NSCLC, RET gene fusion is also this targetable alteration which which are present. It's not very common, but its targetable mutation is there, well-known entity. And sulfacatinib is the highly selective potent RET inhibitor that penetrates the CNS. When it was used in the front line in the Libretto 001, overall response rate was 84% and median PFS was almost 2 years. That is excellent. So this 431 phase 3 trial of first-line sulfacatinib versus chemotherapy plus pembrolizumab designed to inform optimal first-line regime for the patient with the RET fusion positive adenocarcinoma. Current report details finding from the first interim analysis of the Libretto 431 focused on the patient in ITT pembrolizumab population. Next, please. So, study schema, study design, the patient with the unresectable stage 3B, 3C or stage 4 non-squamous NSCLC with RET fusion in the chemo-naive patient for the metastatic disease, ECOG PS must be 0 to 2. Stratification by the geography, brain metastasis, and choice of chemotherapy with pembrolizumab. So it was divided into 2 arms. In first arm, sulfacatinib 160 mg BD. In another arm, platinum-based chemotherapy plus minus pembrolizumab. And the distribution was in 2:1. Initially, it was 1:1, but later amendment was done and it was made to 2:1. Gated primary endpoint was PFS by the BICR in ITT pembrolizumab and ITT population. ITT pembrolizumab was a patient stratified by the investigator intent to receive pembrolizumab along with chemotherapy, and it had to be comprises more than 80% of the ITT population per protocol. Total number was 212. Secondary endpoint was overall survival, overall response rate, duration of response, CNS overall response rate, CNS duration of response, and time to progression in CNS safety. Next. In baseline characteristic were well balanced in the both arm, median age, and females, smoking status, racial, and stage 4 brain metastasis, PD-L1 expression. So all are well balanced. Next. So primary endpoint PFS by the blinded independent central review. We can see the separation of curve beautifully in the both ITT pembrolizumab population and ITT population. In sulfacatinib, it was median PFS was almost 2 years, more than 2 years. And in the pembro arm, it was less than 1 year, approximately 11 months. So sulfacatinib also yield PFS benefit versus control across all pre-planned subgroup. We can see the separation of the curve beautifully in the both picture. Next. So now come to the response and the CNS progression. We can see the efficacy outcome. Overall response rate was 84 and 65 versus 65, which is a huge difference in the all data, like overall response rate 84 versus 65, median duration of response more than 2 years in sulfacatinib, while in pembro arm it is less than 1 year. Intracranial response rate 82% versus 58%, intracranial CR rate 35 versus 16%. 12 months intracranial duration of response was almost 6 years, sorry, 76% and 62% in the pembro arm. So there is a huge difference in all the data. Similarly, in the CNS progression, we can see 12-month cumulative incidence rate was only 5.5% in the sulfacatinib arm, while in chemo plus pembro arm, it is 20%. Hazard ratio was 0.28. In patient without baseline CNS metastasis, 12 months CIA was 1% in sulfacatinib versus 14% in chemo arm. So hazard ratio was 0.17. And patient with CNS metastasis at the baseline, here also we can see 12 months CIR was 25% versus 33%. So hazard ratio is 0.61. OS data immature and confounded by crossover. So we can see in all this thing, incidence rate or duration of response or response rate, there's huge difference. Come to the next. Now come to the safety profile. Here we can see sulfacatinib was exposed to almost 16 months. Median time of treatment was 16 months, while in chemo plus pembro arm, it was only 9 to 10 months. So adverse event, more than grade 3 adverse event was 70% in the sulfatinib arm, while it is in another arm, it is 57%. Death was 4% and 1% due to the treatment, while in another arm, there is no death. Adverse event leading to discontinuation was 10% versus 2%, and dose reduction was noticed in 51% versus 28%. So we can see in toxicity profile, sulfatinib is not doing well. This is very toxic in comparison to the another arm. However, as I mentioned, this treatment duration was more in the sulfatinib arm in comparison to the chemo plus pembro arm. Here, this thing, adverse events, we can see transaminitis was 22% and 13% in the more than grade 3. It is huge. While in another arm, it's 3% and 1%. Similarly, hypertension in 20% patient, more than grade 3 hypertension was noted, while in another arm 3%. So toxicity profile, it's not in favor, not going in favor of the sulfatinib arms. Next. So patient reported outcome in ITT pembro population, we can see sulfatinib delayed time to the deterioration of pulmonary symptom and overall physical function versus chemo plus pembro arm. In both curve, sulfatinib is showing the better result in comparison to the chemo arm. Next. So in conclusion, in phase 3 laboratory 431 trial, first line sulfatinib showed superior efficacy versus chemo plus pembrolizumab in patient with the RET fusion positive MCLC. Sulfatinib significantly improved median PFS versus chemo plus pembro in ITT pembro population. Sulfatinib also improved intracranial response rate and delayed CNS progression. It is sulfatinib associated adverse events were generally consistent with those previously reported and typically can be managed with the dose adjustment. It's delayed time to deterioration of pulmonary symptom and overall physical function. Investigator concluded that sulfatinib should be considered first-line SOC for the RET fusion positive advanced NSCLC and stressed importance of genomic testing at diagnosis to identify possible RET gene fusion mutation to inform the optimal therapy. Thank you.
Thank you, Dr. Kaushal. So, based on this data, do you concur with the investigators' opinion that it should be, used as a first line then as compared to chemo plus pembro?
Yes, sir, definitely. Because the huge difference in the response rate, PFS, we should go. Toxicity is a concern, but these are, I think, manageable toxicity with the dose adjustment. So definitely there is.
So I think hypertension and the abnormalities in the liver function tests were the main toxicities.
Definitely.
Prominent.
Hypertension.
I mean, there was one sudden death and some malnutrition related issue. So I think we have this a new drug which should be considered, in patients with RET fusion. So we need to order for a test which includes RET gene fusions, the NGS, because this is a RNA based, should be an RNA based test because it's a RET fusion. So I think we need to look at our testing to include the RET in the kit. Right. I think we can move on to the next talk, which is going to be by Dr. Chaudhary. Thank you, Dr. Kaushal. Yeah. And he's from Metro Hospital, Noida. And he's going to talk about Keynote 671, where I think he's talking about EFS benefit with neoadjuvant pembro plus chemo, followed by resection, and adjuvant pembro in early stage NSCLC. Dr. Chaudhary.
Hi, sir. Good evening, Dr. Sham, sir.
Yeah, hi, Dr. Chaudhary. Yeah.
Am I audible?
Yeah.
I thank you, organizers, for giving me this opportunity to present this abstract. So, good evening, everyone. I'm going to present this abstract Keynote 671 to begin with. So, this is about the role of pembro in the neoadjuvant setting, followed by surgery, and in adjuvant setting, along with the chemotherapy. So, pembro with chemotherapy versus placebo with chemotherapy. So, background of this Keynote 671 was like PDL1 and L1 inhibitors, we know they are the standard of care in metastatic lung cancer and advanced stage of non-small cell lung cancer. And we also know that they have demonstrated benefit when administered before or after the resection in early stage lung cancer, non-small cell lung cancer. Recently reported phase 3 trials like NeoTorch and AGEM, they have showed a significant EFS benefit with the perioperative approach that includes neoadjuvant as well as the adjuvant PD-1 inhibition. So Keynote 671 was designed to evaluate the perioperative pembro plus chemotherapy in patients with early stage non-small lung cancer. This is the schema of this trial. This is a randomized double-blind phase 3 trial, and the stratification criteria were disease stage 2 versus 3, PDL1 score, the TPS score less than 50 or more than 50, histology-wise squamous versus non-squamous, and geographical region-wise Asian versus non-Asian. Patient with resectable non-small cell lung cancer was selected, stage 2, 3A, and 3B non-small cell with no prior therapy and able to undergo surgery and evaluable with the PDL1. Performance status-wise, ECOG 0 and 1 were selected, and total number of the patient in study was 797. The study arm was pembro 200 milligram in standard doses every 3 weekly, along with the platinum-based chemotherapy depend on the histology. If it is a squamous cell carcinoma, then cisplatin plus gemcitabine with the standard doses 75 milligram per meter square cisplatin, gemcitabine 1000 milligram per meter square day 1, day 8. And in a non-squamous non-small cell lung cancer, pembro plus cisplatin was used. Chemo plus immuno was given for 4 cycles, followed by evaluation, and those patients who were resectable underwent surgery, followed by the adjuvant pembro for up to 13 cycles. In the comparator arm, it was the chemotherapy only along with the placebo. 4 cycles of chemotherapy depending on the histology, whether it is gemcitabine for the squamous cell carcinoma and pemetrexed for the adeno. Again, surgery after 4 cycles, followed by only placebo for 13 cycles. The primary endpoint was the EFS and overall survival. So this was the treatment disposition. Total number of the patients screened were around 1364. Patient randomized were 397. And the patient who completed all the 4 cycles of chemo plus pembro or placebo plus chemotherapy were around 75% patients. So 2/3 of the patient, 3/4 of the patient in the both the arms completed all the planned treatment, planned neoadjuvant chemotherapy. Can we go to back, one slide back, please? And in both the arms, around 80% of the patient underwent the surgery. Those patients who refused surgery for whatever reasons, they underwent the radiotherapy. Those refused the surgery or did not underwent the surgery and non-progressive, they underwent the radiotherapy in the both the arms. This was around 8.8% in the pembro arm and 13.3% in the comparator arm. Next, please. This was the baseline characteristic, and this was more or less matched in the both the arms. Median age was 63 in the both the 63 and 64. Male, mostly patients were male, in around 70% of the patients in the both the arms were male. Coming to the Asian versus non-Asian, around 1/3 of the patient, 30%, 31.2 and 31.3% in the placebo arm were the Asians, remaining 70% were non-Asians. ECOG wise, mostly patients were ECOG 0 with good PS and remaining were the PS1. Histology wise, non-squamous were definitely more than the squamous, 56 in the both arms versus 40% around in squamous carcinoma. Mostly patients were smoker and only 10% were the non-smokers. Stage wise, around 30% of the patients in the both the arms were stage 2, remaining stage 3 around 70%. Coming to stage 3 and 3B, a large number of patients were 3A. Around 50% of the patients, more than 50% of the patients in the both the arms were stage 3A. Nodal status N0 around 37% in the both the arms. So 1/3, 1/3, 1/3 kind of thing. Again, PDL1 status less than 1 to 49 and 50 or more than 50%. Again, one third, one third, one. So patient who underwent surgery were around 98.5% in the pembro arm and 95% in the comparator arm, and mostly patient underwent R0 resection. So 92% in the pembro arm and 84% in the chemotherapy arm. Coming to the result of the keynote 671. So since EFS was the primary endpoint, so we can see at the 12-month around 73% patient in the pembro arm were the event free, and as compared to 59.9% in the placebo arm, chemo plus placebo. Even at the 24 months, in the pembro arm, 62.4% were event free, and 40.6% patient in the chemo plus placebo arm were event free, with the hazard ratio of 0.58. And coming to subgroup analysis. So in all the subgroup, the pembro fared better than the only chemo. So pembro plus chemo was better in all the subgroup EFS wise, whether it was age wise or gender wise, race wise, geographic region wise, smoking and histology wise. Next, please.
Sir, last few seconds.
Yes. So coming to the OS primary endpoint, there was no difference in the OS in the both the arms. Next slide, please. Pathological reviews of pathological. Sorry. Response rate wise, pembro did better than the comparator arm. Next, please. So coming to, please move on to last slides. So conclusion wise, the investigators conclusion one, in patient with resectable stage 2, stage 3A and stage 3B, non-small cell lung cancer, neoadjuvant pembro plus chemotherapy followed by the surgery and adjuvant pembro was associated with significant improvement in EFS versus neoadjuvant chemotherapy and surgery alone. So median EFS not reached in the pembro arm versus 17 months in the placebo with the significant p-value. Overall survival difference was not significantly different in this analysis and will continue to be tested. Perioperative pembro was associated with significant improvement in pathological response rates. Exploratory analysis suggests benefit with pembro regardless of whether patient attend PCR or MPR. Safety profiles were expected based on the individual agents. Investigator concluded that these findings support perioperative pembro as a promising agent, new treatment option for patient with the resectable stage 2, 3A and 3B non-small cell lung cancer.
Right. Thank you, Dr. Chaudhary. So I think the question is, I mean, these are patients who are resectable, most of them.
Yes.
So should we give them chemo, immuno, or we operate them and then give them adjuvant treatment? So I
Right.
think that debate will go on. So what do you think? I mean, should we switch, or we need to wait for more data and the overall survival, curves?
No, sir. In a patient with curative intent, I think we should wait for the overall survival data. When the aim is the curative, then OS should be the criteria. Nonetheless, EFS is also one of the factors we can consider.
Right. So I think
there is this update from Merck actually. In its newsletter on 10th of October this year, they have actually said that the dual endpoint have been met. So both of course, the RFS was the endpoint which was already met, and overall survival also. This is probably the first trial where both in ESMO they have presented, and it is met actually.
okay. So if that data is there, we need to sort of look at that data, and we look forward to the approval from the regulatory to incorporate this combination in the neoadjuvant setting. Okay, we move on to the final talk on this session, which is by Dr. Kapil Goyal. He's consultant at Rajiv Gandhi Cancer Hospital, Niti Bagh. And I think he's going to address the issue of neoadjuvant nivolumab with chemo or adjuvant chemo with nivolumab in patients who have resectable non-small cell lung cancer. This is Checkmate 77T. So over to Dr. Kapil.
Thank you, Dr. Shyam sir, for inviting me here. So today I will be talking about Checkmate 77T trial, so which was a phase 3 trial of neoadjuvant nivolumab with chemotherapy versus placebo plus chemotherapy with adjuvant nivolumab or placebo. The stage 2 to 3B NSCLC. As we know that the combination of chemotherapy along with immunotherapy both is in evolutionary phase these days, and both we have the trial of Keynote 671 and nivolumab, both are also coming into this space. So surely IU is going to revolutionize the neoadjuvant and adjuvant management of such cases. Just to give a brief background, so neoadjuvant nivolumab plus chemotherapy is the standard of care for eligible patient with resectable NSCLC. This was based on the previous Checkmate trial in which there was EFS advantage and where the PATCR was more, although I do not think it is standard of care per se. So a perioperative approach of administering nivolumab with neoadjuvant chemotherapy and as post-surgical adjuvant therapy improved PCR and survival in patient with resectable stage 3A to B NSCLC in an open label phase 2 trial. So they did a randomized double blind phase 3 Checkmate 77T study. This was undertaken to compare neoadjuvant nivolumab and chemotherapy followed by adjuvant nivolumab against neoadjuvant chemotherapy and placebo followed by adjuvant placebo in patient with resectable stage 2 to 3B NSCLC. And this update is up to after the median follow 5.4 months. Coming to the study design, it was a global randomized double-blind phase 3 trial, and in which we took resectable, previously untreated stage 2A, so defined by tumor size more than 4 centimeter, up to stage 3B, that is N2 disease. Also, they had taken NSCLC, performance status 0 to 1, and any driver mutation like EGFR or ALK alteration, they were all ruled out. So 461 of such patients were randomized into 2 arms with stratified by histology like non-squamous or squamous, stage 3 or 2, PDL1 status, that is more than 1% or less than 1%. And so the 2 arms were standard cisplatin or carboplatin plus pemetrexed chemotherapy, in which experimental arm nivolumab was combined to make it as per 3 weeklies. A dose was modified to 360 mg every 3 weeks versus placebo in the neoadjuvant space, followed by surgery within 6 weeks, followed by adjuvant nivolumab for 1 year. And in the control arm, placebo was given for the similar duration. Primary endpoint was event-free survival, and secondary endpoint was PCR, major pathological response, overall survival, and safety. If we look at the baseline characteristics, so the median age was 66 years, in which 73%, almost 70% were male. If you look at the performance status, it was majority of the patient had performance status 0. Disease stage, so most of the patient came from stage 3 and only 1/3 of the patient had stage 2. Looking at the histology, it was equally distributed between adenocarcinoma and squamous carcinoma. 93% patient were either current smoker or former smoker. We have to look closely at the distribution of tumor PD-L1 expression. So 41% patient had less than 1% and 56% patients, almost similar number of patients were less than 1% or more than 1%. But what is interesting is to distribution within more than 1% subset, in which 1/3 patient were having PD-L1 more than 50% and 2/3 patient had 1 to 49% of the patient. Most of the patient received carboplatin and fewer patient received cisplatin in both the arms. So if we look at the treatment and surgical outcomes, so most of the patient completed neoadjuvant therapy, after which 80% of the patient underwent definitive surgery, and only 2/3 of the patient could receive adjuvant treatment as per prescribed. And so the median number of adjuvant treatment doses was 13, which is pretty good. And 16% of the patient in either arm completed adjuvant treatment. Most of the patient underwent lobectomy, with only 10% of the patient in either arm underwent complete pneumonectomy. 90% of the patient in each arm had R0 resection, and rest of the patient had R1 or R2 resection. So overall, if we look at the surgical outcome, they were pretty good. Most of the patient could undergo definitive good quality of surgery, and most of the patient required only lobectomy, and pneumonectomy was not required in many patients, and the treatment completion rate was also very good. If we look at the efficacy outcome of EFS overall, so they are divided in all patients, stage 2 or stage 3. We look at the all patient. So the median EFS was not reached in the nivolumab arm, and chemotherapy arm was about 18.4 months. If we look at the hazard ratio, it was 0.58 with a good statistically significant confidence interval and a statistically significant p-value. If we look at the 12-month EFS, so we'll talk about that. So 73% versus 59%, which is good. And 18 months EFS was also 70% versus 50%, which is also very nice. And hazard ratio as per investigator assessment was 0.56, which is statistically significant. When we divided them into stage 2 and stage 3, stage 2, so here the effect is not seen that clearly, although the median EFS has not reached in either arm. But 12 months EFS was 78% versus 73% in both the arms, and the hazard ratio is not statistically significant. The most of the benefit was seen in stage 3 patients, in which the median EFS was 30.2 months in nivolumab versus 13.4 months in the chemotherapy plus placebo arm. So there is more than doubling of median EFS in patient presenting with stage 3 at presentation with a hazard ratio of 0.51. So the risk of any event happening is reduced by 50% in patient who received nivolumab in stage 3. 12-month EFS also data is also statistically quite significantly favorable for nivolumab arm, that was 71% versus 52%. The more important data is according to the PD-L1 stratification. So if we stratify these patients as per PD-L1 less than 1% or more than 1%, so here we see that the hazard ratio was not significant for PD-L1 less than 1%. Median EFS was 29 months versus 20 months. So while numerically speaking, it sounds nice, but if we look at the hazard ratio, it was only 0.73, which was not statistically significant, 1.15, breaching the margin of 1. If we look at the PD-L1 more than 1%, so here the data suggests that it will not reach in the nivolumab arm and 15.8 months in the chemotherapy arm with the hazard ratio of 0.52, which is significant, and 12-month EFS was 76% versus 54%. So overall, I think we can say that PD-L1 less than 1% patients are not likely to be deriving any benefit from addition of nivolumab, and the benefit would be restricted to PD-L1 more than 1%. However, if we further divide PD-L1 more than 1% into two groups of PD-L1 1 to 49% and more than 50%, to mind you, here we have to see the number of patients. So 1/3 of the patient had out of the PD-L1 more than 1%. In this group, 1/3 patient had PD-L1 more than 50% and 2/3 patient had PD-L1 1 to 49%. Here the median EFS was 30.2 months versus 28.1 months, which is also almost equal with the hazard ratio 0.76, again not reaching confidence interval significance. PD-L1 more than 50% only. Here we see a marvelous, tremendous benefit of nivolumab. So median EFS is not reached after 25 months of follow-up versus only 8 months in the chemotherapy plus placebo arm. Hazard ratio is 0.26, which is with the confidence interval of 0.12 to 0.55, which is statistically significant. Looking at all these data, it looks like the benefit of nivolumab was restricted to patients who had PD-L1 more than 50%. Looking at the other data, the benefit of nivolumab addition was seen in subgroups, which including less than or more than 65-year ECOG performance status, N0, N1, N2, single station, multi-station, squamous adenohistology, and whether the cisplatin or carboplatin has been used. If we look at the pathological complete response, so it was 4.7, only 4.7% in the placebo arm versus 26% in chemotherapy arm, nivolumab arm, which is very good. Which is similar to what we had seen in the previous trial of nivolumab in the neoadjuvant setting. So overall, if we look at the major pathological response, that was also almost tripling of major pathological response with the addition of nivolumab. If we look at the EFS according to the PATCR or MPR pathological
sir.
response.
Sir, kindly
Sorry?
conclude, please.
Yeah. So here we see, so almost all of the patient had benefit of adding nivolumab irrespective of the pathological response and according to as per the adjuvant treatment. If we look at the safety data, the safety data was almost similar in placebo arm versus nivolumab arm, and we did not see any major grade 3 or 4 side effect happening additionally in nivolumab arm. Looking at surgery-related adverse event, 41% for nivolumab arm and 39% for the chemotherapy plus placebo arm, which is similar. To highlight, 2 patients during neoadjuvant treatment in nivolumab arm died because of the treatment-related adverse event. So 1 patient died because of the grade 5 pneumonitis and 1 patient had grade 4 pneumonitis. If we look at immune-mediated adverse event, both the arms, there were no grade 3 or grade 4 side effect in both the arms. It was almost 0 or 1% or less than 1%. To conclude, the neoadjuvant nivolumab plus chemotherapy followed by surgery and adjuvant nivolumab was associated with significant clinically meaningful improvement of EFS in resectable NSCLC patient with the improvement of PCR and MPR. And EFS benefit with perioperative nivolumab was observed in patient with PCR after neoadjuvant chemotherapy and in patient eligible for adjuvant chemotherapy regardless of PCR status. No new safeties finding and similar rate of completed surgery between arms and outcome supported perioperative nivolumab as a potential new treatment option for patient with resectable NSCLC. Thanks a lot. So any question are welcome.
Thank you very much, Dr. Kapil, for
Thanks a lot.
for bringing out this particular study. So I think these kind of studies where people are trying to incorporate neoadjuvant immunotherapy drugs are sort of welcome, but I think we really need to identify subgroups of patients who are really going to benefit. For example, in this study, patients with stage 3 A or B and PDL1 more than 1% got the maximum benefit. So I think there's a need to further dissect these studies and of course look at the overall survival before we start subjecting our patients to all patients of resectable non-small cell lung cancer to neoadjuvant chemo and immune oncology drugs. So I think we're running short of time. So with this, I hand it over back to the organizers and thank you very much for inviting me.
Thank you, sir. And that was some great talks by the 3 speakers. And thanks for concluding, sir. So moving on to the next session, I would like to, and again, it's my privilege to actually invite Dr. B.N. Kapoor, sir. He's the chairperson for the next session, and he currently, sir, is Director of Medical Oncology at Yashoda Cancer Center, Ghaziabad. So welcome, sir. I hand over the next session and proceedings to you.
Thank you very much, the organizer. And I thank Dr. Piyush for giving me the opportunity to chair the session. And it's my proud privilege to introduce Dr. Nitish Garg. He is the Assistant Professor, Medical Oncology of American Oncology Institute, DMC, Ludhiana. And he will be speaking on the ELENA trial, which is a randomized phase 3 trial of adjuvant alectinib versus chemotherapy in patient with stage 1B, 3A, ALK positive non-small cell lung carcinoma. Dr. Nitish Garg, may I request you to start your presentation, please?
Yes, sir. Thank you, sir, for the introduction. And it is actually privileged to be sir, because I have been from AFMC myself. So I'll be, without wasting any more time, I'll be talking about this trial, which is ELENA trial. So let me share my presentation. Okay. Is it visible?
It's not visible yet.
It is loading, sir.
Okay.
Okay, so basically, we know ALK has been a game changer for the patients who have ALK positive NSCLC in the advanced stage lung cancer, and it has provided a greater response, and the EFS overall survival have tremendously improved. Alectinib, specifically after olatinib, has given a great response also because of the high CNS presentation and CNS activity.
Dr. Ankit, would you want the slides?
Is it visible now?
No, it's not visible.
technical support.
I'll just switch off my video.
Yeah, that could help.
Sir, can I share your slides?
Yeah, sure. No issues.
Go ahead, please.
My side, it is showing, it is sharing.
Now it is there.
Okay.
Yeah, you can start your presentation.
Okay. So as I was talking, alectinib and the penetration in the CNS and activity in the advanced NLCLC. So now there is a time and that we shift from advanced stages to early stages and provide our patients a better care and better survival, because we know even if we do a surgery, give them adjuvant chemotherapy or radiotherapy, the responses or the provided by CCO. So to the background of reoccurrence with 45 to 75% of the patient depending upon the stage, and 5% of these patients usually have the ALK. So usually harbor the ALK rearrangement, which are more common in
Garima, you could share the slides and Dr. Nitish, you want
sir,
the slide to take support?
Yeah, I'll just take a moment, sir. Can you just proceed with the other one, because this, I think there is some glitch with the network. So I'll just adjust it and come back. I'm not sure what is happening.
We can come back to you and we can go to the next.
Yeah. Nitish, we will take you later on, I think so. We will start with the other.
Sure, sir.
Yeah.
Sure, sir.
Yeah, thanks. Dr. Ishu, are you ready, please?
Hello, sir. Hi, I'm here.
Yeah. Okay. So the Ishu, we will start with your talk now.
Okay, sir, sure.
Dr. Ishu is the medical oncology consultant Fortis Hospital, Noida, and he will be speaking on the TROPS-3 phase 2 basket trial, which is sacituzumab govitecan as a second-line therapy for extensive stage small cell lung carcinoma. Yeah, Dr. Ishu, you can proceed with your...
Thank you, sir. Thank you for the introduction, and thank you, organizers, for giving me this opportunity. I would be briefly presenting a very good study here, which is the TROPICS-03 basket trial. It's actually a subset of the trial, and this is sacituzumab govitecan as second-line treatment for extensive stage small cell lung cancer. These are the preliminary results. And as we know that small cell lung cancer patients, especially in the extensive stage, they eventually do relapse after the first line. And in the second line or further lines, the treatment options are limited. The treatment responses, the response rates are modest. The clinical benefit is not very impressive. And even if it is, we see that most of the patients, the responses are not durable. And sacituzumab govitecan is a TROP2 directed antibody ADC, and it is approved for second line or further in HER2 negative breast cancer patients, and also in second line and further in urothelial cancer patients. This ongoing TROPICS-2 is a phase 2 trial, which is a basket study evaluating the use of sacituzumab in locally advanced or metastatic solid tumors. Coming to the today's topic, that is the subset of this trial for extensive stage lung cancer, small cell lung cancer patients, and patients who were histologically confirmed to have this disease, had a disease progression after the first line platinum-based therapy and a combination of an anti-PD-L1, atezo, durvalumab, whatever, a measurable disease, ECOG PS 0 to 1. This is important to see that the trial has not included PS2, which is probably the most commonly seen in the relapse setting of a small cell lung cancer. And patients should have a stable CNS mets or not an active CNS mets. There were 40 patients included in this cohort, and they were exposed to sacituzumab on day 1, day 8 basis in the dose of 10 milligrams per kg. The primary endpoints were overall response rates, secondary endpoints being duration of response, PFS, OS, and safety. And the cutoff for the presentation for this preliminary data was July 2023. By this cutoff, there were 30 patients who were enrolled, and a median follow-up for these 30 patients was around 5.1 months. Baseline characters, as expected for a small cell lung cancer patient, median age was somewhere around 67. Most of them were smokers. PS1 patients were usually PS1. 87% patients here were PS1. Initially, to begin with, they were stage 4. And with the first line of therapy, there was 50% patients having a CR or a PR and 33% patients with a stable disease. Now, with this exposure to sacituzumab govitecan, the median duration of the treatment was 3.9 months. Median number of cycles were 6, that is 12 doses. And patients who had discontinued treatment by the end of these 6 months was 19 out of 30. That is a good 63%. Most common cause of discontinuation was disease progression. Efficacy, which was assessed by the investigator, the overall response rate, that is a CR and a PR, was seen in 37% patients, but the disease control rates, which included a stable disease, was an impressive 87%. More so was a CBR, which is a CR plus PR or SD for more than 6 months of the start, and that was in very good 40% of the patients in a second line or later lines in small cell extended stage lung cancer patients. The median duration of response was 6.3 months here. 77% patients had a baseline tumor reduction, and 43% patients had a tumor reduction for more than 30%, as evident from this waterfall graph. Coming to the safety, sacituzumab govitecan was probably well tolerated, safety profile being very similar to what we know from the breast cancer and urothelial cancer studies previously. Most common side effects being diarrhea, neutropenia, fatigue, nausea, but hardly any patient needed discontinuation because of toxicity. So there were 0 out of these 30 patients who were discontinued because of toxicity. Yes, 27% patients did require some dose reduction, but none of them didn't need a discontinuation of therapy. No patient died in this trial because of the treatment toxicity, and that tells us that the safety profile was manageable. Concluding, the investigators have concluded that sacituzumab govitecan can demonstrate a promising efficacy in the second line treatment for patients with ES-SCLC, with a disease control rate of 87% and median duration of response to be 6 months. Manageable safety profile consistent with the known safety profile, no patient leading to a treatment discontinuation or death. And these encouraging results do warrant that a further investigation for this drug should be conducted in this setting. Thank you.
Thank you, Ishu. It was a very good presentation. And second part of the thing was we have got very gratifying results by the use of govitecan, sacituzumab govitecan. The results are promising, and but the duration of the study is very short, 6 months, and probably with the time we will be able to come to know whether this promising drug has a long-lasting effect on the management of extensive stage small cell lung cancer. We have yet to wait for more results to come, and but the initial results are definitely great.
Yes.
Thank you, Ishu. We'll move on to the next talk. And
Dr. Beal, Dr. Nitish sir is available. He messaged me that he can join now.
Ji. Dr. Nitin is ready now?
Yes, sir, I
yes,
think so. He's ready.
Nitin, are you ready?
Yes, sir.
Okay. So shall we start with your talk now?
Sure, sir.
Yeah. Dr. Nitin will be speaking on alectinib versus chemotherapy in 1B, 3A, ALK positive non-small cell lung carcinoma. Yeah.
Thank you, sir, for the introduction. So as I was talking, and thank you for waiting before the glitch. So this ALINA trial basically compared alectinib in the adjuvant form, followed by versus chemotherapy in the post-resection NLCLC patients. So we know that the patients who have been diagnosed with the NLCLC have a high risk of reoccurrence. We know the response rates post-adjuvant therapy are dismal. So only 4 to 5% of the patients harbor this ALK rearrangements, and these are more common in younger age people, non-smokers, and associated with high risk of brain metastasis. So current standard of care treatment in a resection of early ALK positive NLCLC is chemotherapy, surgery followed by chemotherapy, which is adjuvant platinum-based chemotherapy. So alectinib has sorry, am I audible?
Yes, sir.
Yeah.
Yeah, you
So
are audible. You are audible.
alectinib is a potent oral ALK TKI with a high CNS activity, as we have seen in ALK, JLX, and Alicia trials. So in the advanced setting, when we have seen compared to crizotinib in these following trials and demonstrated a robust intracranial activity, making it recommended in the first line, just second to lorlatinib. So lorlatinib, though, is a wonderful drug with a slightly poor tolerability because of the high chances of increase in the sugar levels and also the triglycerides and the lipid profile derangement. So long-term treatment with alectinib is usually well tolerable and without major side effects. So the current reports report details finding from the primary analysis of this phase 3 ALINA trial comparing adjuvant alectinib versus chemotherapy are being reported here. So this is the basic study design. It was a international randomized open label phase 3 trial with almost 30 countries were involved. Asian and non-Asian was a stratification factor, and then the other stratification factor was the staging 1B, where it was more than 4 centimeter, stage 2 versus stage 3A. So the patients who were included are resected stage B1, 1B, 2 and 3A, ALK positive NLCLC, more than 18 years of age, no prior systemic therapy received, ECOG performance status of 0 to 1. So the total number of patients were approximately 260 divided to 1:1 randomization. Alectinib given for 2 years, 600 milligram BID dosing, and platinum-based chemotherapy, which was either pemetrexate plus cisplatin or carboplatin, or either gemcitabine or vinorelbine combination, followed by a follow-up. So the primary endpoint here was the disease-free survival as per the investigator, and it was a hierarchical trial. So depending upon the stage, if there was a response in stage 1A, then the response in stage 2, then the responses in stage 3A, and also the intention to treat population. And the secondary endpoint was CNS disease-free survival, overall survival, and the safety. So if we see the baseline characteristics, they are pretty well matched. No difference in the matching characteristics. The patients who were never smokers were 65 in the alectinib arm and 55 in the chemotherapy arm, compared to the former smokers 32 versus 43%. And Asian population is 55 again. Approximately 55% of the patients were there in the trial. So looking at the staging, it was approximately 10% in stage 1B, 35% in stage 2, and 3A was 55%. So very well matched. Non-squamous histology was mainly included, and the main surgical procedure was lobectomy. So the primary endpoints, if we look at, sorry, so this Kaplan-Meier curve at 2 years and 3 years shows a significant difference, and the graphs start separating at about 3 months exactly. So at 24 months, the difference is almost 30%, and going up to 3 years, 36 months, the difference is still increasing. So there is a significant improvement. So when we see the DFS, the hazard ratio is 0.24. So the disease progression and deaths have been reduced by a relative risk of 76%. So 76% in oncology, I feel, is a great number. But still, it is just the DFS, and we would like to look at the overall survival also. So coming to the coming to the intention to treat population, which included almost all this, mostly the same population, the responses were still the same. So looking at the DFS according to the stage 1B had a hazard ratio of 0.21. So that was the hierarchical design. So they had a response in stage 1B. So then it was followed up in stage 2 and then subsequently in stage 3. So almost everywhere the responses were great and the reduction in relative risk of progression and death was reduced to a significant level. So coming to the CNS disease-free survival and the overall survival is still immature and has not been reported. So till now, the trial has been followed up for approximately more than 3 years. So the CNS disease-free survival rates have improved by approximately at 2 years by 12% and at 3 years by 15%. And if we see the recurrence rates or the extent of the recurrence and the sites of recurrence, everywhere it has shown a tremendous response and reduction in the recurrences. So look at the local recurrences and the distant recurrences, 22 versus 3 compared to local recurrences 9 versus 22. So there has been a tremendous response. And then the brain metastasis 14 versus 4. So this is the impact of the targeted therapy or the precision medicine in oncology, and it has shown that this drug can be a practice-changing drug in ALK positive rearranged NLCLC. So looking at the subsequent therapy post-reoccurrence, there is a significant reduction in the numbers compared to the chemotherapy arm. So this is in the range of 15s, and here it is touching 30 to 40. So alectinib was used only in 4 patients. Here, when chemotherapy was given, it was 29 patients. Brigatinib was used again. It was comparable because we usually don't use brigatinib. And so these were the things. Chemotherapy in 6 patients, and there it was only 2 patients. So radiotherapy and surgery was also in lesser number of patients. So safety profile, we know alectinib can cause increase in LFTs and increase in CPK levels, usually well tolerable, not much of the side effects. So chemotherapy associated with nausea, vomiting, constipation, anemia. So grade 5 side effects were not seen. Median treatment duration with alectinib, as it was well tolerable, was about 2 years, and with chemotherapy it was only 2 months. So the side effect profile was very good. And at the data cutoff, approximately at more than 3 years, 20.3% patients are still on alectinib arm. So the investigators concluded that ALINA represents the first and the only positive phase 3 trial of alectinib used in adjuvant setting in stage 1B and 3A NLCLC. Adjuvant alectinib shows superior efficacy versus chemotherapy in patients with resectable 1B, 3A ALK rearranged NLCLC with the DFS of disease, the recurrence relative risk reduction by 76% and the CNS relative risk reduction by 78%. And it is a very well tolerable drug with no unexpected safety signals. So investigator concluded that adjuvant alectinib represent an important treatment strategy for the patients with resectable strategy. Only thing which I would like to wait for is the overall survival and what are the responses with the fusion partner. So there can be some changes with the ALK fusion partner. The responses may be better in few, the responses may be lesser in some. Thank you.
Yeah, thank you, Nitin. Very nice presentation. The point is, alectinib has been found to be effective versus chemotherapy in resected non-small cell lung carcinoma. Probably in a lab situation also with brain metastasis. This was patients in which they were adjuvant given alectinib. but renal metastasis may be in relapse situation also probably it is showing some better response after renal metastasis. Promising results, 2-year studies, probably one can think of using alectinib in the adjuvant setting in resected non-small cell lung cancer. Thank you very much, Nitin, and we'll move
Thank
on
you,
to
sir.
the. Thank you. For the next talk, I would invite Dr. Sahil Kambru.
Dr. BN, sir.
Yeah.
Yeah.
Dr. Sahil sir is not able to join right now due to some personal reason.
Okay.
So AstraZeneca talk will be presented by Dr. Piyush, sir.
Okay. So I will invite Dr. Piyush for the next presentation, and you will be speaking on Tropion trial.
So I would be speaking on the ADAURA.
Okay. You will be speaking on osimertinib in early EGFR non-small cell lung cancer, ADAURA trial. Yeah, Dr. Piyush.
So I hope my slide is visible over there.
Yeah, it is visible.
We'll just try to minimize these things on the screen. So, I would be talking on as pitched right after Alina, ADAURA. So these two TKIs, as we understand that, are actually changing the way we are treating biomarker-driven early NSCLC. So talking about early lung cancer and how often we see it, this is what the data says, that approximately 30 to 33% would be actually presenting in an early stage. And in those terms, they would be probably amenable to local therapy, especially surgery, especially the stage 1B, 2, and 3A. So these are the ones which are actually operable. So these are the number of patients who would undergo the knife. So we know that adjuvant chemotherapy, cisplatin-based chemotherapy, has been used, and this has definitely a 5% incremental benefit in terms of overall survival. So these are from the this data is from the meta-analysis. So also, if this is used in the neoadjuvant setting, quite a similar figure. So basically, if you look at the hazard ratio in terms of the benefit, so this is to the tune of around 0.84, the DFS hazard ratio. The overall survival hazard ratio is around in the tune of 0.89. So I just open my printer. Yeah. So if you look at the based on these number of limited studies, the mutations are quite similar. So in the Asian population, it is around 30 to 40%, and in Caucasian, it's around 10 to 20% in the advanced stage. However, the data of what is the EGFR prevalence in the early stage is a bit coming in now, trickling in. So we can see that's quite similar data. More so, something interesting is that in Asian population, you find that in stage 1, there is more preponderance of EGFR in the early stage. Look at those figures in stage 1, stage 2. It is more higher than what you find in stage 4. So this is something interesting. Talking about osimertinib as adjuvant therapy in patients with stage 1B and 3A, EGFR mutation positive NSCLC after complete tumor resection, then this was ADAURA. So we have seen the trial's initial data in 2020 NEJM, and now eventually overall survival analysis published in 2023. So both the analysis are out. If you look at the overall trial design, so it was actually including stage 1B, 2, and 3A NSCLC with or without adjuvant chemotherapy. So minded chemotherapy was allowed, and chemotherapy was taken by around 60% of the patients in both the arms. So if you look at the other aspects, it was good performance status, and
L858R and exon 19 deletion were the two main subsets which were actually included. Brain imaging. So brain imaging was, essential, whether you get a CT scan or a MRI. So this was there. And of course, post-surgery, if in case a patient has received chemotherapy, then patient needs to be included into the trial at least 26 weeks with adjuvant chemotherapy. If not, then 10 weeks without adjuvant chemotherapy. And then stratification was done by stage, the type of EGFR mutation, the race. Osimertinib in its standard dose was given and was randomized with placebo in a 1:1 fashion. Nearly 682 patients were taken, and planned treatment duration was for 3 years. Treatment continued till disease recurrence, either treatment is completed or discontinuation criteria met. So follow-up until recurrence was at week 12 and 24, and then at regular intervals. Important thing is that the primary endpoint was DFS by investigator assessment in stage 2 and 3A patients, and designed for superiority under the assumed DFS HR of 0.7. Secondary endpoint, DFS in overall population, and DFS at 2, 3, 4, and 5 years, overall survival, and of course, health-related quality of life issues, as in other trials, was also looked upon. Looking at the inclusion criteria, as I mentioned earlier, this was it. And as I mentioned, an MRI or CT scan of the brain prior to surgery. So although the practice now is MRI for every patient. Exclusion criteria, if you look at it, of course, if any radiotherapy prior was given, preoperative chemotherapy, and other aspects, including that the segmentectomies or wedge resections were actually excluded. And of course, any comorbids which were actually hindering with osimertinib delivery were excluded. So baseline characteristic quite well balanced. When the study started, it was actually the duration of, AJCC 7th edition was being followed. Then there was certain stage migration when AJCC 8 was adopted, when the results started trickling in. So otherwise, quite a balanced arms. The EGFR mutation, exon 19 and L858R 55-45 in both the arms, as you can see, and adjuvant chemotherapy 60-40 ratio in both the arms, as you can see over here. Updated primary analysis in the stage 2 and 3A, you see the hazard ratio over there, 0.23 in terms of median DFS, very impressive. And in the overall population, if you look at the situation, median DFS 65.8 months for osimertinib. Look at the hazard ratio over there, 0.27. So as expected, stage 1 would do slightly better in terms of survival. So hazard ratio slightly increased over there. Talking about 4-year DFS analysis, osimertinib 4-year DFS around 80 versus 59, and stage 2 74-42, and stage 3A 65-14. So you see the maximum delta in stage 3A over there. Looking at the subset analysis, well, all the subsets, of course, benefited, and something which was there, that exon 19, of course, as you see that the benefit is more. Adjuvant chemotherapy, the benefit is more, but nonetheless, not getting chemotherapy also, the benefit is pretty significant, clinically significant. So early snapshot, overall survival in stage 2 and 3. So patients and investigators remain blinded to the treatment in order to facilitate assessment of overall survival at maturity. Here it says NR, but actually now the overall survival is positive for this particular study, although that was not the primary endpoint. So looking at the previous data set, all the studies, as you can see, it all started with CTONG 1104 with geftinib of 2 years. And then all these studies started coming in, positive studies. They did show a DFS benefit. Some, like BR19, was a negative study. So the type of recurrence is a key consideration in NSCLC. Brain recurrences are more in EGFR positive subset. So here, if what we look at it, that in ADAURA, the brain recurrences were lesser, with osimertinib being used in adjuvant scenario. What sort of recurrences? Well, the recurrences were more so loco-regional.
So loco-regional recurrences, as you can see that in the orange box, the stint is 38%. Loco-regional recurrences were nearly 62%. So sites of disease recurrences, the most common recurrences were in lung, lymph nodes, and CNS were very few in the osimertinib group. So as you can see, hazard ratio of 0.24 in terms of CNS DFS events. And safety summary, as we are quite aware, was quite similar to what we have been using with osimertinib and seeing with osimertinib. And also the interstitial lung disease, we are aware that we have to look out for it. 3% of patients did have some grade 1 and grade 2 interstitial lung disease. QTC is something, again, when we are using these TKIs, we have to look out for the same. Talking about postoperative chemotherapy use and outcomes from ADAURA. So, adjuvant chemotherapy use. Now, remembering the previous forest plot analysis, both these subsets were benefiting. Those who used chemotherapy and those who weren't using chemotherapy. So, where to use actually chemotherapy? Now, look at this, stage 1B in particular. So, if you are using chemotherapy, how many patients got chemotherapy? Nearly 26% got chemotherapy in stage 1B, right? So if you look at DFS in overall population with chemotherapy, without chemotherapy, so you get a decent delta. HR ratio is nearly quite similar, 0.16 and 0.23 with and without. But if you sort of stage split it and see stage 1B, so here they have not put, the other comparator with adjuvant chemotherapy in stage 1B. But if you look at this particular graph, you see that the curves basically are not quite wide separated over here. So with adjuvant chemotherapy in stage 1B, the curves are not quite wide separated. But if you look at stage 2, look at the separation. It is pretty impressive, hazard ratio of 0.15. And if you look at stage 3, with adjuvant chemotherapy, it is also impressive. So basically, there was a discussion that in stage 1B, probably giving chemotherapy first and then followed by osimertinib could have led to progression of patients. And therefore, in stage 1B, adjuvant chemotherapy can be avoided and osimertinib can be used straight away. Talking about the quality of life analysis, SF36 scale was used, and it has both the physical component summary as well as
Sir, kindly conclude, please.
Mental component summary. So compliance was present, and it was basically found that overall time compliance with SF36 health survey were high, more than 85%. So to conclude, there is definitely a DFS benefit of 65.8 months in osimertinib versus 21.9 months. And so these updated data, now with the overall survival benefit also there, reinforce adjuvant osimertinib as the standard of care in EGFR mutated early stage lung cancer post complete tumor resection with or without adjuvant chemotherapy. Thank you.
Thank you, Dr. Piyush. Nicely presented the data on osimertinib and resected lung cancer. A lot of new things are coming in use of resection after as an adjuvant therapy, and small TKI has been found to be effective in ALK positive and EGFR positive, osimertinib and EGFR positive lung cancer. So probably it becomes a standard of care to use such drugs, multi-TKIs in resected lung cancer also.
So Dr. Kapoor, Dr. Sham here. Good evening.
Ji, sir. How are you, sir?
I put the question in the chat box.
Yes,
I mean, for the patient with stage 3 after surgery, EGFR positive, did we give chemo or no chemo, or just the osimertinib?
Me, sir, I do prefer chemotherapy.
I think Piyush, what is the, verdict?
I think so. Stage 1B is the one where chemotherapy better we can avoid and straight away start with osimertinib, because it was seen that delay in.
If you look at the, the hazard ratio with or without chemo, I mean, there's hardly 0.15 and
Not much of a
0.2.
difference, sir.
So, I mean, why should we, like in Alina study, they never gave chemo, with alectinib.
Yes, sir. The only the thing is, sir, if we look at the overall survival analysis, actually, what I feel that the curve is actually, although I mean, is still at 5 years, they have still got a very good overall survival benefit. But is it like, are we looking at a cure, or are we looking at just a statistical overall survival eventually? Because the curve is sort of going towards a banana shape, what I feel. So, the hazard ratio also increased to 0.58 from what the DFS benefit was to start with, that 0.24, and then it sort of has gone to 0.58. So that is something, sir, to of course add chemotherapy over there if in case we are eventually looking at postponing a relapse. Of course, the overall survival benefit has come, though the trial did not look at it as a primary endpoint.
Okay, thank you. It's a debatable.
Thank you very much. Thank you, Dr. Piyush, and thank the organizer. And I now hand over the mic to the organizer.
Can we take you next as your for your next talk?
Yeah, we can proceed. Yeah.
Most welcome. So, Dr. Vinod Sharma, he's a medical oncologist at AIIMS, and he's a consultant at HCG Cancer Hospital, Jaipur. He would be presenting phase 2 EVOKE 02 first-line sacituzumab with pembrolizumab in metastatic NSCLC.
So, thank you to the organizers. A very good evening to all the attendees. So, we will be discussing this important phase 2 study where the combination of two drugs, sacituzumab govitecan and pembrolizumab, in metastatic non-small cell lung cancer in first line. So in driver negative mutation NSCLC, the first line therapy is...
Hello, sir. Sir, can you please just make it full screen?
Okay, just a minute. So it's now full screen?
Yes, sir. Fine, sir.
Okay, thank you. So we know that sacituzumab govitecan, it is a anti-TROP2 directed ADC. The sacituzumab part is related to the immunoglobulin, and the govitecan is related to the SN28, that is the active metabolite of irinotecan, which is a topoisomerase 1 inhibitor, leading to a single-stranded DNA break. So already this drug is approved in TNBC in third line, in metastatic setting, in hormone positive, in third line post-endocrine therapy, and post-platinum and immune checkpoint inhibitor in metastatic urinary bladder cancer. The initial phase studies, there was a durable response, and actually this was a phase 2 part where it was combined with pembrolizumab in multiple cohort studies. So this analysis is part of cohort A and B. So the rationale behind this study is that this study is recently published in Clinical Cancer Research in last week. So there, in retrospective analysis, where immunotherapy and chemotherapy was used, so it was found that TROP2 is associated with primary resistance to immune check inhibitors. So this is the OS analysis where the patient which had high TROP expression, they have a poor overall survival when treated with immunotherapy, but not with chemotherapy. So here the patient, they received atezolizumab, not chemotherapy. So probably combining a TROP2 inhibitor might be able to overcome the immune resistance in these patients. So I think this was the rationale. So this it was a phase 2 study already mentioned, biomarker driver mutation negative. So we will be discussing the cohort A and cohort B. The cohort A was more than 50% TPS expression, both squamous and non-squamous histology. The cohort B was less than 50%. There is a short follow-up that is to be actually undermined, that the follow-up was only 5 months. So the standard dosage of sacituzumab was used 10 mg per kg day 1, day 8, every Q21 days. and the standard doses of pembrolizumab. The primary endpoint, as with all phase 2 studies, we usually see is the overall response rate and the dose limiting toxicity for the carboplatin arm C and D, the cohort C and D, but they are not being, I don't think they are published. Coming to the baseline characteristic, so the common age group, median age 67 years, between 60 to 70, most were males, and the white population, 60% non-squamous, and stage 4 upfront were 80%. So similar actually distribution in both the cohort. Coming to the median duration of treatment, as the median follow-up was only 5 months, the median duration of treatment for sacituzumab and pembrolizumab both were about 4.1 to 3.6 months. The median number of cycles were 6, and almost 2/3 of the patients were continuing treatment. And the most common reason for treatment discontinuation was progressive disease. Coming to efficacy endpoint, so the overall response rate was 69% in the more than 50% TPS cohort, and it was 44% in the less than 50%. Most were partial response. There was none with complete response, and the progressive disease were like in digits only, 10% and 6%. So as I think these response rate were quite remarkable. Disease control rate of 90%. And if we see median duration of response was 6-month duration of response was 90% in both the arms. So the overall response rate was quite remarkable. So coming to the this waterfall plot chart, the most of the patient, there was a tumor reduction was there. There hardly progressive disease, or we have seen that it was almost 10% or less than 10%. So coming to these spider plot chart, so most of the patient responded. So I am not able to make out any pseudo progression. So most of the were like below the line, and there was one or few spider plots that were above the line. None is there that is going up and then showing a response. So out of these limited number of patients, no pseudo progression is there. Moving further, so the treatment related toxicities. So grade 3 toxicities were almost 70%, and out of these like serious were 54%. So these treatment leading to discontinuation, significant number, almost 20%. 20% there was required reduction in the sacituzumab govitecan, and 14% discontinued. So there were almost 6 deaths. One was related due to sepsis. As we know that sacituzumab govitecan lead to myelosuppression, neutropenia, and other. So coming to individual toxicities, so most common toxicities with sacituzumab, as we have seen in triple negative breast cancer ASCENT trials, say most common were diarrhea and the bone marrow suppression related anemia, alopecia, neutropenia. It is a moderately toxic drug, emetogenic drug. So there was a nausea component also there, and alopecia, almost 37% had alopecia. And there were the pneumonitis rate was almost 2 patients had pneumonitis.
Hello, sir. Sir, kindly conclude, please.
Okay. So coming to the conclusion, the overall response rate and disease control rate for the more than 50% cohort was 69 and 86%. And for less than 50%, it was 44% and 78%. The 6-month disease control rate was 88%. The classical toxicities was there with sacituzumab. The phase 3 EVOKE-3 study is open to recruitment from this year only, and the result will come in 2027. So we have to wait for next 4 years to get the result, whether whether sacituzumab can have any place in the frontline setting in more than 50% PD-L1 TPS score patients. So thank you very much. I conclude here.
Thank you so much, Dr. Vinod. That's some exciting study again. So next, I would like to invite Dr. Lalit Sharma. So it's my privilege to invite him. He's a consultant medical oncologist at Manipal Hospital, Jaipur,
We'll be speaking on Hartina, Lung 1 phase 2 trial of patritumab deruxtecan in previously treated EGFR mutated advanced NSCLC. So Dr. Lalit, it's over to you.
Good evening, everyone. Can I request the organizers to kindly share the slides? Thank you. I hope these slides are visible. So the job cut out for me today evening is to discuss the Harthina Lung 01 trial. So this is a phase 2 trial, and this has examined the efficacy of patritumab deruxtecan in previously treated EGFR mutated advanced non-small cell lung carcinoma. Next slide, please. Next. So as we know, the EGFR TKIs are the standard of care at this point in time in EGFR mutated advanced non-small cell carcinomas, but almost all of these patients would subsequently develop resistance and would fail on these particular therapies. And we also know that the subsequently introduced platinum-based chemotherapies have limited responses in these particular patients, and the salvage therapy is only offer transient benefits. So we have been looking for the molecules which could help us improve the outcomes in this particular subset of non-small cell lung carcinoma. And as in other oncological disorders, we have resorted to antibody and drug conjugates. So one such antibody drug conjugate which is being studied now is the combination of HER3 and directed antibody drug conjugate. That is, now this has three parts. The first part is a fully human anti-HER3 IgG1 monoclonal antibody. The drug conjugate here is high potency topoisomerase 1 inhibitor payload, that is DXD, which is a exatecan derivative, and it has a very short systemic half-life. The linker is basically a tetrapeptide based cleavable molecule, and this was the safety profile was studied in a phase 1 study, and it did show that it was effective in EGFR mutated advanced non-small cell lung carcinoma with diverse mechanism of resistance to EGFR TKIs. Now, Harthina Lung 01, this is the phase 2 trial which studied in patients who have kind of progressed on EGFR TKI and platinum-based chemotherapy. Next slide, please. So basically, the study enrolled patients who had advanced EGFR mutated non-small cell lung carcinoma and were on recent systemic therapy, had received some sort of prior treatment with an EGFR TKI and a platinum-based chemotherapy also. Inactive or previously treated asymptomatic brain mets were allowed, and pre-treatment tissue biopsy was required but was not selected for any HER3 expression. Patients were divided into two arms. The first arm had a fixed dose combination of fixed dose were delivered fixed dose in the dose of 5.6 milligram per kg, and the other arm, there was an 3-weekly up titration of the therapy, wherein the cycle 1 was given at a dose of 3.2 milligram per kg, with cycle 2 given at 6.4 and 4.8, sorry, and the third cycle was given at a dose of 6.4 milligram per kg. The majority of the patients were in the fixed dose combination arm. The median follow-up for this particular arm was 18.9 months, and median duration of treatment was 5.5 months. So the primary endpoint was a confirmed overall response rate, and the secondary endpoint was duration of response in this particular study. So as far as the demographics are concerned, patients ranging from 37 years to 82 years were enrolled in this particular study with a median age of 64. A majority of the patients were female, around 60%, and there was a decent representation of the Asian population, 47%. Most of the patients were ECOG performance score 0 or 1, and the median time since initial diagnosis was around 41 months. The history of CNS metastasis was present in around 50%, with brain metastasis at baseline in almost 1/3 of the patients, and liver metastasis at baseline also in almost 1/3 of the patients. The more common mutation which was seen was exon 19 deletion in 63%, and 36% had L858R mutation. Majority of the patients had received around, more than 2 prior lines of therapy, that is the EGFR TKI and the platinum-based chemotherapy. And most of these patients received the 3rd generation EGFR TKI, that is osimertinib. So the baseline coming to the efficacy summary. Yeah, please go ahead. So coming to the efficacy summary, around 73% of these patients showed a disease control rate. Only one patient showed an CR. Majority showed either a stable disease or partial response. Almost 44% showed stable disease, and 29% showed a partial response. The median duration of response was 6.4 months, and the median PFS was 5.5 months. The median overall survival was 11.9 months. And when the subset analysis was done, it was seen that probably the elderly patients, that is patients who were more than 65 years, showed slightly better response as compared to the younger patients. Males fared slightly better as compared to the females, and the Asians somehow showed slightly lesser response as compared to whites or other races. L858R mutation patients showed slightly better response as compared to exon 19 deletion. Patients who had brain mets, history of brain mets, fared slightly poorer as compared to who did not have a brain mets to start with. Interestingly, patients who were exposed to prior immuno-oncology drugs fared better as compared to who had no exposure to IO molecules. And patients who had been exposed to more than 2 lines of therapy fared significantly better as compared to those who were exposed to 2 lines of therapy. So next slide, please. If we see this plot, this does tell us that the efficacy was maintained across the diverse EGFR TKI resistance mechanisms. Next slide, please. Next. And even the response was maintained in patients who had initial presentation with brain metastasis, but were not offered any sort of treatment in the form of radiotherapy. Around 33% overall response rate was seen in these particular patients, and a significant number of patients, that is 9 patients, showed a complete response in this particular subset, around 30%. Whereas majority showed stable disease, and 3% showed partial response. So the disease control rate was an impressive 76%, that too in a population which had been exposed to multiple line of therapies before being introduced on this particular therapy. And the median duration of response was 8.4 months. Next slide, please. As far as the safety summaries profile is considered, the most common safety concern was nausea, but most of these patients had a grade 1 or 2 nausea. The grade 3 or more, that is the serious side effects, were seen in the form of cytopenias, be it the thrombocytopenia, neutropenia, or leukopenias. The majority of the patients had some degree of treatment-related side effects, but the treatment was discontinued in only 7% of patients due to the therapy, though a large number of patients did had to either interrupt the dose or have needed dose reductions also. The interstitial lung disease was seen in 5% of the patients, but majority of these were either grade 1 or grade 2. Only say around 1 to 1.5% had grade 3 or severe interstitial lung disease. Next slide, please. So as per the investigators' conclusion, the phase 2 Harthina lung 01 examined fixed dose that is 5.6 milligram per kg of this molecule, and it showed durable anti-tumor activity with an overall response 8%, and this disease control rate of 73% and a duration of response of 6.4 months. And this efficacy was preserved across diverse EGFR TKI resistance mechanisms. And the intracranial anti-tumor activity was observed in patients with untreated brain metastasis also, with intracranial confirmed overall response rate of around say 33% and an intracranial disease response rate of 76%. As far as the safety profile is concerned, only 7% of the patient had to discontinue treatment due to adverse events, and a significant interstitial lung disease was seen in around 5.3% of the patients. So the investigators concluded that this molecule represents a promising therapy for patients with EGFR mutated non-small cell lung carcinoma after failure with EGFR TKI and a platinum-based chemotherapy. Thank you for a patient hearing. Over to the organizers.
Thank you, Dr. Lalit. So in the interest of time, we can actually take the questions in the chat box. I would move forward towards another talk. And to deliver this, we have Dr. Rajat Saha. He's a dear friend and senior consultant and unit head at RGCI. So he would be presenting on Destiny Lung 02 phase 2 trial of trastuzumab deruxtecan in patients with previously treated HER2 mutated metastatic NSCLC. So what do you, Dr. Rajat?
Thank you very much, Dr. Piyush, for inviting me. And I would like the organizers to just flash the slide set on screen. So I was hearing the previous speaker on a tongue. It's kind of a tongue twister, deruxtecan, and I would be just elaborating on the Destiny Lung 02, which is a phase 2 trial of trastuzumab deruxtecan, which has been there for quite a long time. We would be getting it soon in the Indian markets too, in patients with previously treated HER2 mutated metastatic NSCLC. Next slide, please. So the background of this trial was that approximately 3% of advanced lung adenocarcinomas harbor the HER2 mutations. Now, trastuzumab deruxtecan HER2-directed antibody conjugated to a topoisomerase 1 inhibitor payload has got multiple FDA-approved indications, mainly currently in the breast cancer arena. In August 2022, FDA granted accelerated approval for trastuzumab deruxtecan dosed at 5.4 milligram per kg every 3 weekly in adults with unresectable or metastatic NSCLCs harboring and activating HER2 mutation who were treated with some prior systemic therapy. So accelerated approval has been based on the Destiny Lung 01 trial and the Destiny Lung 02 trials. So the current trial, which I'm going to discuss right now, is basically the primary analysis of the Destiny Lung 02 trial, evaluating the efficacy and the safety of 2 dose regimens. One is at 5.4 milligram per kg 3 weekly, or the second dose is 6.4 milligram per kg 3 weekly in previously treated HER2 mutated metastatic NSCLC. Next slide, please. So this is the study schema. The patients were metastatic HER2 mutated NSCLC with equal to or more than one previous line of anti-cancer therapy, which includes a platinum-based therapy. There were 2 doses of trastuzumab deruxtecan which were tested. One is the standard 5.4 milligram per kg every 3 weekly, and the second one was 6.4 milligram per kg every 3 weekly, randomized in a 2:1 proportion. The primary endpoint was the overall response rates, and the secondary endpoints were obviously the overall response rates by the investigator, the duration of response, and the safety analysis. Next slide, please. So this was the baseline characteristics, the baseline demographic characteristics. 102 patients randomized to 5.4 milligram per kg and 50 patients randomized to 6.4 milligrams per kg. Next slide, please. So let us quickly go to the results of this trial by the blinded independent committee report. The response rates, the primary endpoint, this was the primary endpoint, and the response rates was 49% in patients with 5.4 milligram per kg and slightly higher 56% in patients with 6.4 milligrams per kg. The disease control rate was 93.1% in 5.4 milligram per kg and 92% in the higher dosage arm. The median duration of response was essentially similar. The median time to initial response was also essentially similar at 1.8 months and 1.6 months. In each arm, the lower limit of the 95 confidence interval exceeded the benchmark of 26.4%. So the investigators had initially planned for a benchmark of 26.4% overall response rate. And both the trial arms, the 5.4 milligram per kg and 6.4 milligram per kg, both showed way above response rates at 49% and 56%. Next slide, please. So this is the waterfall plot of the 5.4 milligram, the lower dose, 5.4 milligram per kg. So here we can see a fantastic response across the majority of the patients, and only about a handful of patients, 4 patients did not show any response, and about 4 patients showed progression. And the response rates were irrespective of the HER2 mutation domain site. So almost all the patients kind of responded. Next slide, please. So this is the waterfall plot of the 6.4 milligram per kg dosage, the higher dosage. Here also we have got an impressive waterfall plot with almost all patients, barring about 4 patients, which showed a response. And again, in this, the kinase domain was studied, but most of the patients were from the same kinase domain mutation. Next slide, please. So this is the survival curves. Here we can see that the progression-free survival with the lower dose regimen was 9.9 months with 5.4 milligram per kg, and the PFS with the 6.4 milligram per kg was 15.4 months. So definitely it is better with the 6.4 milligram per kg. The OS was 19.5 months with the lower dose, and it is not evaluable as of date with the 6.4 milligram per kg. Next slide, please. So now let us come to the safety summary of the lower dose as well as the higher dose. Here we can see that the grade 3 or more side effects are definitely more in the higher dose regimen of 6.4 milligram per kg. And there were 2 deaths reported in the trial, one from the lower dose arm and one from the higher dose arm. Next slide, please. So the one of the most commonly discussed adverse events with the trastuzumab deruxtecan is the incidence of ILD. And let us see what happened to the ILD incidence in the lower dose regimen and higher dose regimen. The higher dose regimen definitely had higher rates of ILD, and the grade 3 or more ILDs were means the any grade ILDs were definitely higher in the 6.4 milligram per kg arm. There was no recurrence of ILD or pneumonitis observed in 2 patients with grade 1 events who were retreated with the deruxtecan. Next slide, please. So the conclusion of the investigators from the Destiny Lung 02 trial was that this was a primary efficacy analysis and safety analysis of these two dose regimens. The overall response rates was 49% in the lower dose rate arm and the 56% in the higher dose arm. For each dose range, definitely the overall response rate far exceeded the benchmark of 26.4%. And the safety profile at both doses were consistent with the previous studies. And here we can see that the ILD rates were definitely more in the 6.4 milligram per kg. At the end of this trial, the investigators concluded that trastuzumab deruxtecan be dosed at 5.4 milligram per kg as the standard of care for patients with previously treated HER2 mutated NSCLC. This is because there is no major improvement in the overall response rates with the higher dose regimens. And so the investigator felt that the optimum dose regimen should remain at 5.4 milligram per kg. So thank you very much for giving me the opportunity. Over to the organizers. Thank you, Dr. Piyush.
Thank you, Dr. Rajat. So with this, I think so we can move to the panel discussion. I think so we have Dr. Bhuvan with us right now. Dr. Bhuvan?
Hey, hi. I thought there was one more talk. They told me Dr. Piyush is also going to discuss one. Were you discussing one more abstract?
Okay, one was actually left out. So can we straight away go for the panel discussion and then we can take as depending on the time. So are you comfortable?
Another 2 minutes I would have reached home. So anyway, I'll start. Don't worry.
I can actually present. So if in case you want to go ahead, we can go ahead with the panel.
If you can present, that'll be better.
Okay.
I'll be in a much better position. Because it's
have...
going to be a half an hour discussion, right? So
yeah. Garima, I would request that if in case we can project Dr. Sahil's slides.
Yes, sir. Yes, sir.
As we understand that ADCs are actually, making a noise in lung cancer, what Dr. Rajat presented, and then before that, Dr. Lalit. So again, this is one ADC again, a TROP2 inhibitor, datopotamab, and these tongue twisters are going to increase, I think so. So here, this is a Tropion study. So as you can understand, Tropion as in TROP2 inhibitor, in Tropion Lung 01, it was pitched against docetaxel for previously treated advanced metastatic NSCLC. Next slide, please. So second line, as we understand, is standard of care so far right now in non-biomarker driven NSCLC post chemoimmuno is actually chemotherapy. So we go ahead and look towards chemotherapy and we get some PFS and of course more needs to be done in that particular arena. We are seeing shorter PFS, but there was this anti-VEGF trial of ramucirumab and docetaxel, which was showing some survival benefit. And now this particular study is there. So DATO-DXd is a ADC targeting TROP2 with the topoisomerase 1 inhibitor payload. And the phase 1 part of the study, Tropion Pan-Tumor 01 trial showed promising anti-tumor activity in advanced metastatic NSCLC with 26% overall response rate. Current analysis reports efficacy and safety of this molecule versus docetaxel in patients with previously treated advanced NSCLC enrolled on phase 3 Tropion Lung 1 trial. Next slide, please. So looking at the design of the study, it was an open label phase 3 trial and stratified by histology, squamous versus non-squamous, actionable genomic alteration present, and of course the geography, which continent, and anti-PD-1 or PD-L1 monoclonal antibody in most recent prior therapy. So these were the stratification criteria, and it was all advanced lung cancer patients who had received previous therapies, and they were randomized to dato-DXd 6 mg per kg 3-weekly therapy, with docetaxel being 3-weekly therapy. Almost equal patients in both the arms. So patients with actionable genomic mutations 1 to 2 lines, including platinum-based chemotherapy and anti-PD-1 monoclonal antibodies. So prior approved targeted therapies, all patients were included. So dual primary endpoints were PFS and overall survival. Secondary endpoints were overall response rate, duration of response, and safety. Next slide, please. So looking at this baseline characteristics, as you can see, non-squamous was the predominant form of histology over here. Apart from that, actionable mutations, you can see a few patients were actually having actionable mutations. EGFR was the predominant one over there. And around 15%, 17% were actually brain metastasis at baseline. Prior therapies, so of course, these were heavily pretreated subsets. Even 2 lines of therapies were taken, 36% and 33% respectively, as you can see in prior 2 lines of therapy. And of course, as you see that a lot of non-biomarker driven subset was there. So patients would have got some immunotherapy, 88% in both the arms respectively, along with the chemotherapy. So next slide, please. So talking about the efficacy of the drug, eventually the endpoints, median PFS 4.4 versus 3.7 turned out to be statistically significant with the HR of 0.75. Median PFS follow-up was 10.9 versus 9.6 months. A median overall survival of 12.4 and 11 months. And overall response rates, if you look, CR were 4% and none in the docetaxel. PR, good number of patients in PR, 75% versus 39. And duration of responses, 7.1 versus 5.6 months. So a PFS benefit, which was the primary endpoint, was actually achieved. Next slide, please. Now, if we split the histologies, we look at the HR, and clearly adenocarcinoma or non-squamous histology is the clear winner over there. Overall survival going to 0.77 in hazard ratio, duration of response 7.7 versus 5.6 months, overall response rate 31% versus 12.8 months. For the squamous histology, this advantage was not there. Next slide, please. So talking about the safety, so again, we are concerned about pneumonitis, and this again was an issue over here. So this particular thing, nearly pneumonitis and septic shock was there in 1 death in each. Next slide. So adverse events of special interest, discontinuation due to the investigated drug. So there was 0.7% patients discontinuing it because of stomatitis. And there were grade 5 ILD events in 7 patients. And there were some ocular events as well. So dry eye and increased lacrimation is it's there with the other ADC as well. Next slide, please. So to conclude, in this second line space, there is this ADC coming up. A greater benefit is seen in patients with non-squamous histology. Interim overall survival favors dato-DXd, and survival follow-up is ongoing. And of course, ILD is something where there were patients who died. So this requires careful monitoring and management. So investigators concluded that this ADC is a potential new treatment for previously treated non-squamous cell NSCLC. So with this, I would want to go ahead, inviting Dr. Bhuvan, if Dr. Bhuvan has reached his destination.
Yes.
Wow. So that was quick. So Dr. Bhuvan is a dear friend, and he's a senior consultant medical oncologist at Max Super Specialty Hospital, Saket. So Dr. Bhuvan, you would be moderating this panel, and you would invite your panelists.
Yes. So thank you, Dr. Piyush, for this opportunity and a rather interesting topic. And I was really glad this topic came, because I think the management of a driver mutation addicted lung cancer has changed quite a bit in last 2 months. I'd like to invite my panelists. I think I can see Dr. Aparna is there. I can see I think Amit Verma is there. I can see Dr. Anuradha is there. And I think Dr. Vikas Talreja was also supposed to be there. He's there. And then Dr. Rakesh. I don't see Rakesh. Is he there around somewhere? Tech support, is Rakesh joining in? Can you just give a heads up about that?
Sir, he is not picking a call. Maybe he's not
Okay.
joining, so.
So we have, and it's a rather good thing. So we have Vikas to drop in about medical oncology. I think Dr. Piyush, you can join in, because it's a rather interesting panel, and it's something which I really want med-onc opinion also. So moving forward, I'll just share my screen once again.
Rakesh sir will be, sir.
It's okay. We'll proceed then. So let's start with the driver mutation addicted panel, and I'll take you across two EGFR positive cases, and I think that's where quite a lot of changes have happened. So just to set the context, we basically had my slides are visible, right, everybody?
Yes, they are.
Yes.
So great. So moving forward, the case is about a 64-year-old female. She is diabetic, has presented to emergency somewhere in December of 2020. There's acute shortness of breath from past 3-4 days. She is breathless at rest. There's orthopnea. There's swelling over the face for last 3-4 days, and there's decreased urine output for 2-3 days. So this is the CT scan. It shows a lung mass. There is a large pericardial effusion. This is the effusion which is there, and then there is a lung mass. The cardiology evaluation shows the standard pericardial effusion ECG. There is a low voltage with sinus tachycardia. The echo is otherwise the the systolic functions are well, but then there is a pericardial effusion noted which has been drained out. So this echo was done after the pericardial effusion was drained out. So pericardial drainage has shown cells fluid which is positive for malignancy, and we made a cell block out of the pericardial effusion. It is positive for malignant cells. It's a malignant effusion, adenocarcinoma. The cells express CK7 and IPCAM. It's negative for the usual IHC markers. It's basically is not taken us anywhere. And we have started the patient on a standard Abraxane. And from there, we have sent a molecular studies, because we possibly think that it's most probably a lung primary in a non-smoker Asian female. And it has come out to be exon 19 deletion positive. So now, up till I think, if I'm not wrong, if I'm talking about 2020, possibly EGFR was still not, it was still exon 19 deletion, and there was a L858R, and there were some rare mutations. So my question to the molecular oncologists on the panel is, and I'll start with alphabetically. I think it will be Amit, Aparna, and Dr. Anuradha. So Dr. Amit, how do you see the expanse of the world of EGFR mutation positive lung cancer? Do you still categorize them as one disease, or are we hair splitting there?
Basically, Bhuvan, I'm at home actually. I'm sorry, but I'm not called beta.
We all are at home.
Yeah. So I think the things I expand. Exon 19 deletion, but we're trying to also go beyond that, the location of deletion, the responses to the drugs, the site deletion basically, and further, the rare mutations what we are picking up in the EGFR, the insertions, the deletions, the indels. So we are going beyond what we used to do before actually. And there are certain nuances what we are focusing, but at the same time we are learning. Still, things are not very clear to all of us what is the right way to predict, but yes, certainly we have some idea of responses, it's going to be great or not that great actually.
Fair enough.
Cool.
So, are you continuing? I think because you are breaking in a bit, so I'm not able to make it out the continuing. Or...
Okay. Okay, sorry. So I'm done actually. You can take the next question actually.
So, Dr. Radha, let's alphabetically you
Yeah.
come up with A and then A, B. Sorry, I said that. But so how do you see it? So instead of giving me as a Tata, when you come across samples, how do you in your head have started splitting the EGFRs, positive lung cancers?
Yeah. Good evening. See, that has been done real-time PCR, right? It's been done by real-time PCR, but it is not on the NGS. Exactly.
Yes, in this case, it is
when
not been
exon
done.
19, which is a very the cell block, right? So in case whenever we do it on real-time PCR, we had certain limitations because all the exon 19 also is not covered in the real-time PCR. So there may be a missing some indels into this where the patient must and they must have been present if we would have done the NGS. But yes, there must have that is why the response must have been low. But as I said, like why not NGS was done on this patient? Was there any limitation?
So let's
But
go
if you
into this
go,
case a little later. I understand. I hear your question.
yeah.
So I understand you asking me a very valid question. Why not do an NGS? And I accept your point. So my point to you is a bit further. In today's world, let's not put it in 2020. Let's put it in 2023 December or 2024 January, if you want to call it as. Are you still categorizing EGFR as exon 19, exon 21 and rare? Or there is something else which you are doing to EGFR any further now?
No. We look upon for exon 18 as well, and in exon 20, we look upon other than a T790M mutation because many times we get some de novo, but we also need to look upon the deletions, exon 20 insertions and deletion, and S768I mutation. So right now with a single gene EGFR, yes, we need to look all of this in a very extensive mode, but other than the EGFR, we need to go beyond that. We need to look for PDL1, we need to look for ALK, we need to look for retros and so many things. But as this single gene matter, EGFR, we have to do the extensive study, just not on the real-time PCR because many a times those mutations are not picked up on the real-time PCR because it's a hotspot mutation many times on the real-time PCR.
I understand. So Dr. Aparna, other than the EGFR, what other partner mutations do you look out for whenever you're advising your clinicians in terms of EGFR drugs? What other partner mutations which you're looking out for?
So I think with NGS coming in, we are going beyond EGFR, right? So we're seeing a lot of EGFR with TP53. I think that's one of the most common concomitant mutations that we are seeing. We know that there is data where you can have EGFR and TP53, where maybe just doing standalone TKI may not really be beneficial, and you need to maybe add a chemo arm. Again, not for role. You need to go back, check the data for which it was approved. In addition to that, we're also now starting to see with EGFR, you could have a PIK3CA lurking behind, which could be a resistance mutation. We are seeing sometimes EGFR with ALK, we're seeing EGFR with ROS1. So as we go ahead and we do NGS, what we are starting to see is a lot of concomitant mutations and other drivers that could be presenting together in this. So for me, I tend to look at NGS and then see what's happening and then make a decision.
Yeah, so I think you all said it right.
Yeah, that's what I said. Yeah. We need to look beyond real time.
So let's move forward. Fair. I think you make a very valid point, Dr. Radha. So moving forward, so Dr. Piyush and Dr. Vikas, what would be in today's world and era? But would your treatment options be same in today's world and era? So I'll ask Dr. Piyush, you first, and then Dr. Vikas. How would you approach a patient in today's world and era when it comes to a EGFR mutated lung cancer? Upfront. So we're talking about the first line as yet. We'll move on to the second line at a bit time.
Yeah, I think so. What Dr. Aparna rightly pointed out that TP53 associated EGFR would not do so well. I think so. FLORA2 has some data on that.
So
And
then let's put these relevant questions in place. When you ask Flora 2, I'll ask you these 5 questions, which I think we can split between you and Vikas. Is there a greater risk than benefit in doing a TKI chemo combination? Is the TKI osimertinib chemo combination better than geftinib chemo combination? Can it improve the Flora 2 OS? Does benefit of TKI chemo, is it only seen in a special subgroup? And what do we do about the resistant mechanisms? So I think let's split this thing questions. So when you talk about Flora 2 upfront first line, let's address these questions.
Giving osimertinib with chemotherapy has not been much of a issue, but also except for the transaminitis and the biochemical issues that we need to look, biochemical monitoring of the parameters which we need to look. I think so. If you're talking about in your first question, that is the major thing that is a bit of a botheration.
So I am bothered about the increase in the adverse effect of it. So if you look at the grade 3 adverse effect, they are 11% versus 54%. And the serious adverse effect increased from 5% to 20%. And so this is what adding a chemo, a PEM-based chemo does to osimertinib. So what I'm asking you is it something which you would advise for everybody, or is it still something you will take an individual decision?
No, of course. I mean, we have to, if it's just after doing a NGS, if we just realize it's just a exon 19 and no other concomitant mutations as in TP53, we can consider osimertinib alone. Exon 19, after all, is one mutation subset where the PFS has been fairly good. So if in case other TP53 like mutations are there, then of course to consider addition of chemotherapy over there. If you look at the grade 3 beyond adverse effects, they weren't quite high. Of course, grade 1 and 2 definitely would increase with the addition of another drug to TKI.
What is your take on a combination of, let's say, a geftinib or erlotinib pemcambro versus osimertinib pemcam?
Again, the similar challenges are there. I mean, we need to watch out more closely for the adverse effect, but then they have been largely pretty well now understood. We have been monitoring these patients, and I have been, practicing the Tata Memorial data which was there. So I think so. It's quite doable for those who weren't able to go for third generation TKI to gain that additional PFS benefit.
So would there be any clinical scenario, and if a patient can afford osimertinib, you'll do a gem chemo versus osi chemo?
A GEF chemo versus osimertinib chemo. So I'm not sure about that. Yeah.
Okay. So Vikas, I'll have to come to you. There is some other options also. There is the data which has been presented by. So there is a data which has come out, and then there is also data. But so do you think Aussie chemo, does it stand equal to possibly a lazertinib amivantamab combination, or a let's say a osimertinib plus ramucirumab combination? Do you have a particular preference there, or if you have to choose a combination? I'm talking about that. Dr. Vikas?
Because I can see.
I can also see. Anyway, so I think I'll move ahead with this question. Anyway, so what I could gather was that if you have to make a combination choice, I think osimertinib chemo has the most robust data as yet. Obviously the OS data is not there as yet. So I'll probably prefer osimertinib single agent, but if I have to make a choice, osimertinib plus chemo, I think has slightly more robust data as compared to osimertinib plus ramucirumab. I think in Indian scenario, lazertinib is not there, so I think J&J will have to get us that drug. But otherwise, lazertinib plus amivantamab may become a combination. But I think the toxicity of amivantamab also has to be considered. I think we all need to have our learning curve with amivantamab toxicity before we're able to do it in regular practice. It has not been able to improve OS as yet. So there has been a slight improvement in the PFS2, but the overall survival curves are almost they overlap each other. So till the time the OS data is not there, I don't think we'll be able to definitely say that the FLORA2 data is something which we should all be practicing. And I think the OS data has to be looked out into before we go make a practice. Special subgroup, I think Vikas, have you come back, or I think still not there, but anyway. So moving forward, what I've realized is there are 2-3 subgroups in which obviously the FLORA2 was the most successful. I think one was with CNS metastasis. There's been a huge improvement in the hazard ratio for the progression-free survival when you do a OC chemo combination as compared to a single agent OC. And I think the similar improvement was also there with TP53. I think if I remember correctly, I don't see it here, but I think there was some evidence of having a concordant mutation and then adding a chemo help there. So I think that was there. Resistance mechanism, I think we all still need to learn because we are still learning about the osimertinib resistance mechanism. How will a osimertinib plus chemo resistance mechanism play out? I think that will be something very interesting. So moving forward, the patient was started on osimertinib, did well. There was a complete response noted in October 21, and then there was a complete response in March 22 also. In June 22, there was a slight increase in the uptake in the region of the primary lesion, and considering that there was basically oligoprogression. So because there was a slight oligoprogression, we treated with an SBRT in July 22. So basically, the initial PFS which gave us was from December 2020 to June 2022. There was an 18 months PFS on single agent osimertinib, and this was the thing which came out in I think this was finished in June 2022. November 2022, and then in June 23 there was a significant increase in the size of the lesion. So if you can see that the lesion which was this in November 2022 had increased to this by the June 2023, and this is where we so because it was a stable disease in 22 November, June, March 23, and then there was a progression in June 23 noted.
There was no radiation given for oligoprogression, or was it?
There was given. So it was in June 22. It was given.
July. Okay.
So this is 23 now. So basically, we're looking at a time duration of 30 months from. So we started in December 20. There was an interim radiation given in June 22, and then we continued osimertinib, and the total duration now is 30 months. And this is where we are sitting at. So, Dr. Piyush, what will be your further plan to it? And then we can have a discussion about.
So I think so. Time for a biopsy right now. We need to have, if it's like a florid progression, then I would want tissue biopsy as well. I mean, of course, liquid biopsy would give a more comprehensive picture, but tissue biopsy for transformation if it's like a florid progression.
So I take your point. What we did was we started the patient on PEMCARB, and while we undertook a biopsy, and by the time the patient had come for the second cycle of PEMCARB, I think that report was available. Also, by the time the patient came from the second cycle of PEMCARB, there was a further worsening of the disease. So if you look at the initial, this is what we're looking at initially. And by the time the patient came back for the second cycle of PEMCARB, this is what the disease was. So and I think that morning itself or the day before, we had gotten the report of the NGS, and this is the NGS report. And I think we can have the molecular oncologist dive back in again together, which I'll give you 2-3 minutes to I'll give you 2-3 minutes to go through the report, because I think you anyway get a lot of time to read these reports, but I think this is like on the spot.
I can do that, Bhuvan. Shall I?
Yeah. Please, Dr. Amit. Yeah.
Yeah. So I think we are able to see the standard mutation, the del19, which is already evident. But top of it, there is C797S alteration, which is, I think, an acquired mutation. That is what I can understand. Followed by the possible explanation, why did the first TKI fail, comes from the explanation coming from the STK11, which is downstream of the EGFR. These are two important alterations which I'm able to see, which explain. But though they are saying it is a VUS missense, but can explain the possible quick failure of the EGFR TKI. Other than RAD52, RAD50, ERBB2, I think can be ignored because they are not, the ERBB2 is not lying in the kinase domain and it is also a VUS, can be ignored. RAD50 again, the VAF here is 48, probably it is a germline VUS, which needs some investigation, may make the patient eligible possibly for some PARP inhibitor later on, but not as of now. But TP53 is the one which again carries a poor prognostic factor, but 49% in the tissue biopsy with a pathogenic mutation. Am I dealing with a Leaf-Romani syndrome? Has to be discussed actually. But you said, you already mentioned germline not detected. Germline not detected. I'm sorry. This is, so fair enough. So this is a poor prognostic case based on TP53, based on the secondary mutation and STK as well, STK11.
So I think let's move on to before you give away all the answers, let's let other people also contribute. So Dr. Anuradha, your interpretation of it, and
Yeah.
I think if it has almost been done by, if there is something add, please add, and then quickly, what will be your treatment recommendation, and then we'll go to Aparna about the next questions.
Yeah. As we see the C797, which is acquired resistant mutation for the osimertinib, we can think beyond that, either with the third line generation or with the osimertinib plus chemo again. But having said that, I see the TP53 is a pathogenic mutation with 49% in tissue biopsy. But you mentioned that it's not confirmed, it's not present in the germline, right? But with the 49%, it can be a heterozygous familial gene as well. But again, we need to verify whether is there any family history or not with the patient's family.
There is no family
But yes,
history.
other than that, I don't think no family history. But 49% is like close to your heterozygous mutation as well. But again, yes, rest of the thing are US, but we need to take a close look for the ERBB2 as well and the STK11. That's my
Okay. So Dr. Aparna, I think would you want to give a comment or two, but then we'll want to hear to the treatment recommendation also.
I think I would obviously third generation EGFR. You can't re-challenge with osimertinib because C797S is a known acquired resistance mutation to osimertinib. So you'd obviously have to use another EGFR TKI, a third generation, and you'd have to add a chemotherapy arm in this for sure. That's what
I agree.
Now, what I did was I dwelled into it. I reached out to the molecular oncologist because it was a bit puzzled. So what I understood from a very classical teaching was that I need to look at the C797S as it is a cis or a trans. But then when you delve into it, what I got to know is that you can't name a C797S as a cis or a trans till the time you don't have a T790M. Because essentially you're looking at exon 20. And
absolutely right.
So if you're looking at if you don't have an exon 20 mutation, you will never be able to call out a C797S as a cis or a trans. And because this length of the DNA is 50 base pairs, in this way we're unable to call out as a cis or a trans. So what we realize is because there is no T790M and the patient has the standard exon 19, what I ended up doing was that I started her on a single agent geftinib on 1st of August. And then we repeated a scan on the 9th of August. And this was the response there. So within, I think, 10 days, she came back to us with a pleuritic pain. And then we did HRCT because I was really worried that the patient is going to progress. But then the entire tumor had magically responded very well. Now, this was the mutation change which had happened because of C7NS and a single agent geftinib, nothing else. There is no chemo which had been added to it. Now the problem doesn't end up there. The problem ends up is that we have done a PET scan after 3 months. The PET scan still shows a stable response in the lung, almost a stable response, but there is a new supraclavicular node which has come up. And I think this is where I would like Dr. Piyush to come in and ask him that what is his further plan. That how would you want to deal with a patient who has had a failure of osimertinib? We gave her the first line TKI. Now I'm starting at a single small increase in supraclav node. And to be very frank, I have told the patient to observe it for 4 to 6 weeks and then, or possibly get a biopsy done from a supraclav node to understand what is happening. But then I'm asking myself,
Can I ask one question over here? Can I ask one?
Yeah.
Since the baseline real-time PCR was the methodology which was used, so did we miss de novo T790M mutation at that time?
But then it should have shown up in the NGS, is it not?
Yeah, but we did the NGS right now, and the patient has come back with a recurrence. And now on the osimertinib, we must have missed, and we are getting this T797S.
Hello, sir. Sir, sorry for intervening. Sir, kindly conclude in 2 minutes, sir.
Okay. Anyway, that was my question. We can think it later.
So, Dr. Piyush, what will be your take on it? I don't think I have the time for next case, but yes, this is fine.
So for now, I had used ABCP in such patients, but ABCP, we are always skeptical when we are using it in EGFR subset. Mariposa 2, the combination appears to be the chemo amivantamab combination appears to be.
So it appears to be rather, to me, it appears very interesting now, okay, that I can give them because the patient still doesn't have has not changed. If there is a slight bit of EGFR dependence, doing a amivantamab plus chemotherapy may have some role, is what I'm thinking for myself.
There has been another revised data of ABCP, if I'm not wrong, which has come up. More.
Atlas, is it? We'll talk about the Atlas data which had come out.
Yes, there is a recent, I'm not remembering the...
Atlas data.
Yes, which is again showing that in EGFR subset, it is succeeding actually. So
I think that concludes it. Do we have time for another 2 minutes? Can I just delve into this?
Bhuvan, I wanted to add that on progression on gefitinib, I think it was prudent to get another NGS on liquid biopsy to understand what happened. Why did not
that's what
stick?
The plan is that only. It's just that I've kept her on gefitinib still, and I'm planning to get a supraclav biopsy as well as get a liquid biopsy done, and so that we can figure out what is there.
Yes, exactly.
Liquid biopsy was done previously, right? At the same time, it showed some 1%.
It was done previously at the same time.
Yeah. So you need to have a repeat
progression.
biopsy. Do we need to repeat for liquid biopsy again?
Yeah, especially on gefitinib, if they have progressed, if there is progression, a liquid biopsy will help know if any other resistance acquired mutations are there. Maybe it's not EGFR, maybe it could be something else. So we have seen in the past that a one-off rare mutation does get picked up.
Just another case, 2 minutes. So there is another not a young male. So what is his age? 60-year-old male who's a non-smoker, has had a lung cancer, who's had a dual mutation. There's a S768I and there's L858R. So to my molecular oncologist, 3 of them sitting there, it's a good thing to ask you. Afatinib or osimertinib? I think one answer is good enough. Dr. Amit, your take on S768I plus L858R.
So 858 are osimertinib, but 7681, then it will be afatinib. So I would choose osimertinib in this case.
Is any of you saying osimertinib or all of you are saying?
No. So I'm saying if it was a single.
I would go with afatinib. Yeah, please.
Dr. Amit,
please,
you
Dr.
were saying.
Sorry to interrupt.
I was saying that if it was not a compound mutation, then definitely choice of 768I would have been afatinib. But once you have the compound mutation, I think the most potent should be applied first, actually. And as we already know, even for 768, the first line osimertinib is also approved, actually.
So you're saying osimertinib, and Dr. Anuradha is saying afatinib. Aparna, I think your vote is going to be tilting the entire thing. Batao, tum kya karne wali, afatinib versus osimertinib?
I am leaning towards afatinib. Just
So,
because.
This is the data which was presented in this WCLC, which I think was a phase 2 data of osimertinib to rare mutations. And So as Dr. Amit said, there is some response to osimertinib, to S768I also. And if you look at the waterfalls plot here, there is some data to it. But just to the cut to the chase, I started the patient on afatinib, has done well from April 22 to I think September 23. It gave him around 15 months. And now there is a progression. Again, at this progression, I've done a liquid biopsy because solid biopsy is not possible. It still shows the EGFR S768I, L858R. There is a VUS, which but I think working with all the molecular oncologists, I've realized there's nothing called as VUS. All of you keep killing us on this is not a VUS, this is not a VUS. I've started also, so as to say it, Google scholaring all the VUSs to pick out if any of them are not the real VUS or not. So now my question to you, all of you, is, first of all, I ran them through the databases I know. The MET is a point mutation. It should not be a pathogenic mutation. PIK3CA is again a point mutation, which is still not a pathogenic mutation. And MAP3 kinase is, I don't think, how will it interfere in this? So do any of you think that any of these three, PIK3CA, MAP kinase or MET, can be a pathogenic in it?
I understand this is a liquid biopsy, but the percentage is below 1%. I don't know whether we should really take it.
No, it is
into
5%,
consideration.
5%, 2%, not
5%
1%.
or 0.05%?
No, it is 5%. No, it is 5%.
Okay. Then we can consider PIK3CA. We can consider
Yeah.
for PIK3CA.
But it should be pathogenic
inhibitor.
also, right? This PIK3 is not pathogenic. I OncoKP.
Yes,
Not a classical location, but we
Not
have
a
to see the functional implication. We cannot just randomly talk about just seeing the
Absolutely.
mutation like this. Yeah.
So how do you see that? You OncoKP it? Or
Yeah, right.
that's what you do, right? We OncoKP it, right? Fair. So now question to all of you is, I have started the patient on osimertinib plus chemo because I going back to what Dr. Amit said, that I still think there may be some juice left in EGFR, and I want to target the EGFR along with chemo. So I've done Osi plus, I've basically done a FLAURA2 for him. Now I'm asking myself, should I be doing a Mariposa 2 for him, or should I be sticking to a FLAURA2 for him? Considering that amivantamab, nobody knows how it works it's a bispecific antibody, works for MET as well as EGFR, but nobody still understands how does amivantamab acts to the MET. So there is amplification, there's a doubt right there. So do you think any of you, and you can come back to me later also, and I can rather reach out to you later also, do any of you think that amivantamab plus chemo would have a slightly more edge over doing a FLAURA2?
After the answer, I'm afraid we'll have to.
Well, I will still
fast.
consider FLAURA2 for this case. Yeah.
Okay. So anyway, thank you. Sorry for taking extra time.
Thank you. That was
Thank you for
interesting cases. Yeah.
Interesting cases. Yeah. Thank you.
Thank you, Bhavan.
Thank you, Dr. Amit. Yeah, and
thank you all the panelists. And I usually forget to say thank you because I get so excited. Thank you, Dr. Amit. Thank you, Dr. Piyush. Thank you, Dr. Parna. Thank you, Dr. Radha. And Vikas, you are not there. So
okay,
thank you, Bhavan.
So coming to the last talk, and so this is again very exciting. Vision for METEX 14 skipping patients in SLC, and this is going to be presented by Dr. Pooja Babbar. So she's a consultant medical oncologist at CK Birla Hospital, Gurgaon. So Dr. Pooja.
Good evening, sir.
Yeah, a very good evening.
Am I audible?
Yes, very well.
Thank you, Dr. Piyush, sir, for giving me this opportunity to speak on vision for MET exon 14 skipping non-small cell lung cancer patient, that is vision. So we'll start with meeting objective and disease background. So the objective of this talk is to highlight the importance of testing for MET exon 14 skipping mutations and also to share insight into management of these patients and treatment guidelines. As we have discussed in previous slide, that it is non-small cell lung cancer is account for 80 to 85% of lung cancer cases. It is probably the most common cancers in male and third most common cancers in female. And it also is one of the most common cancer in terms of mortality. Now, as we all know that lung cancer is an oncogenic driver mutation derived cancer. And molecular testing is of paramount importance in identifying patient with non-squamous non-small cell lung cancer who may benefit from targeted therapy. Now, what is the advantage of biomarker? As we have seen with the previous speaker, very clearly demonstrating, and as we all know, being medical oncologists, what is the importance of molecular testing and biomarker testing in patients with non-small cell lung cancer, how it makes a very critical parameter in treatment decision. It helps to identify patients who are more likely to benefit from treatment. It also reduces the adverse effect, cost, more outcome, and as well as improving the quality of life. So which all mutation do you routinely test? As we all know, probably the most preferred is broad molecular profiling covering each one of them. And as per NCCN guidelines, the category 1 is EGFR, ALK, and PDL1, but we do molecular whenever we get the chance, and now most of us are doing broader molecular profile covering all the most common mutation. As we know, EGFR is the most common mutation followed by ALK, but the rest mutation are at least 2 to 3%, ROS, 1B, RAF, NTRK, MET is 3 to 4%, RET is 2%, KRAS is 30%, 20 to 30%, and PDL1 testing. So now what is MET? So MET is a receptor tyrosine kinase, and it has a growth factor, which is hepatocyte growth factor. So whenever there is an alteration in MET gene, which could either be MET exon 14 skipping mutation, it could be MET amplification, it could be more copy numbers, and whatever be the alteration, it actually disrupts the MET signaling pathway. So this skipping actually result in MET protein lacking a juxtamembrane domain, and that particular domain is responsible for these MET receptor degradation. So once there is a mutation, so we lack that domain which is responsible for degradation, which results in increasing the number of MET receptors. Since they are not degraded, increased expression of MET upregulate downstream signaling pathways, which are RAS, RAF, MAP, ERK, PI3, AKT, JAK-STAT pathways. So according to Asian Thoracic Oncology Research Group, it's a review article that also mentioned testing for MET exon 14 skipping mutation. Since this mutation is seen in 3 to 4% of patients, there are various techniques to detect this mutation, starting from IHC. IHC is just for IHC is not a validated method to test MET exon 14 mutation, nor we take it into account. Either for amplification, we can use FISH, RT-PCR we can use, and the most preferred method is NGS. Which assay do we prefer? Could be both DNA and RNA, and a hybrid would definitely be more preferred, since RNA give us the advantages of detecting more fusions, more transcripts. But again, RNA does get degraded while making a block, so difficult to extract mutations. Though the sensitivity is more, and it actually upregulates the detection of mutation by 1 to 2% in case of MET exon skipping mutation. So it can be detected by both, by DNA as well as RNA. Now DNA is large throughput, it has high accuracy sensitivity. We know NGS can actually detect multiple genes. We can simultaneously detect multiple genetic alteration. RT-PCR is also highly sensitive, more sensitive to detect fusion transcript at RNA levels. But again, there's a poor quality of FFPA, and there's a degradation of RNA while making blocks. Sanger sequence actually detect all the possible mutation in the analyzed fragment, but the sensitivity is low. So RNA supplements DNA-based NGS testing, and the incidence of MET exon 14 skipping detection is more with RNA-based versus DNA-based. It is 4.2 versus 1.3%. What is the most preferred biopsy method? Tissue is always the most preferred method. If not available, then liquid biopsy. Now, biopsy method for detecting MET exon 14 skipping mutation, as I have already explained in the earlier slide, that tissue is the preferred method. We can isolate both DNA and RNA. We can do an hybrid or DNA-based or an RNA-based NGS testing. Second is blood sampling, where we can isolate cell-free DNA and CTC isolation, and we can process it for genetic testing, including RT-PCR and NGS. Both are complementary approach. It actually provide increased flexibility. Now, while tissue biopsy is the gold standard for testing MET exon 14 mutation, but liquid biopsy also is complementary and provides additional value and flexibility. As we can see, more accessible is liquid biopsy. It is non-invasive. It's a blood sample. Risk of complication is less, and though sensitivity is more in tissue biopsy, and liquid biopsy is suitable for all the patients. So meeting the unmet need in MET exon 14 skipping mutations. So which is your preferred treatment recommendation? Select one. For the patient with MET exon 14 skipping alteration, chemoimmuno or MET TKI. So as per recent guidelines, as per the trials which we have seen, either it is profile, vision, or geometry, MET TKI has shown greater response rate, progression-free survival, and even overall survival as compared to chemoimmuno. So now this is OS in patient with MET exon 14 skipping mutation in non-small cell lung cancer. We can see with chemo, the OS is 8 months. With MET inhibitor, the OS reaches up to 24 months. So despite high PD-L1 expression, still immunotherapy shows a minimal benefit. The response rate is only 17%, even in the patient who has high PD-L1 expression, even in those who have, though these mutation has low TMB, but even in the patient who have high TMB, the response is still poor with immunotherapy. So it is an unmet need. The need is not met by chemotherapy, not met by immunotherapy. What next? So as I have already explained in the previous slide, the response rate is 17% with immunotherapy. It is depicted in slide. The progression-free survival is 2.7 months and OS is hardly a year with immunotherapy. And with MET inhibitor, the progression-free survival is up to 15 months, which was hardly 2 to 3 months with immunotherapy. And MET inhibitors achieve OS up to 30 months, which was hardly a year. So guidelines also now recommend MET inhibitor as a standard of care in patients with MET exon 14 skipping non-small cell lung cancer. And the preferred first line of therapy according to NCCN guideline is tepotinib, capmatinib, because they are more specific. Their IC50 is also low, and their off-target kinase mechanisms are generally less as compared to crizotinib, which is a generalized inhibitor, which inhibit ALK and ROS also, as we have seen with other mutation. So it is not so specific drug as compared to tepotinib and capmatinib, and both are now recommended as first-line therapy in MET exon 14 skipping mutations. So Vision trial, it's the largest study. It includes more than 300 patients since it's being a rare mutation, 3 to 4%. It has a good amount of patient, more than 300. It's a first clinical trial, which is actually prospectively enrolling patient based on both. It is not only including tissue biopsy, as like in geometry trial, where only tissue biopsies were there, or in profile trial. Here we have both tissue as well as liquid biopsy. The good part is the median age of patients which were included is more than 70 years. As we know, MET exon 14 skipping mutation, the median age is in the older age group, more than 65, more than 70 years. And it is line agnostic. It studies with both treatment naive. So it has included both the patient either in the first line, second, or the patient who has been exposed to 2 to 3 lines of therapy. And it has also included patient who have upfront brain metastasis. It has included 18% of patient. So it is a single arm phase 2 trial. And the inclusion criteria is a metastatic non-small cell MET exon 14 skipping mutation, could be detected either by a liquid or a tumor biopsy, could have a prior therapy and could have no prior therapy. Both the cohorts are included. The dose of tepotinib is 450 mg per oral once a day. It's 225 mg strength, so 2 tablets has to be taken. Now coming to the baseline characteristics, as we can see, both treatment naive and previously treated, the median age is 74, 71 years. Half of the patients are male, good ECOG performance status. Half of the patient had smoking history. Majority of the patient has adenocarcinoma. Usually MET exon 14 mutations are seen in adenosquamous adenocarcinoma or sarcomatoid carcinoma, though it is also seen in few patients of squamous cell carcinoma, accounting to 7 to 10%. 17 to 19% of the patient had brain metastasis, and we had one cohort representing treatment naive patient and other representing patient who has been exposed to 2 and more than 2 lines of therapy. The primary endpoint, since it's a phase 2 trial, is overall response rate, duration of response, PFS, OS, and safety analysis. It's a first clinical trial of MET inhibitor, and it is prospectively enrolling the patient with MET alteration based on both liquid and or tissue biopsy. As we can see, the liquid biopsy, it's 36%, tissue is 42%, and 20% is both liquid and tissue. And we have seen the characteristics between the tissue
Hello,
and
ma'am.
liquid group.
Ma'am, kindly conclude, please.
Yeah. So we can see the response rate. It is tissue plus patient. So liquid biopsy, when a MET exon 14 mutation is detected in liquid biopsy, it is associated with worse prognosis. And if we talk about efficacy in treatment naive, the response rate is more than 60%. Duration of response is reaching up to 4 months, progression-free survival 16 months, and OS going up to 30 months. This is in the treatment naive patients. And the patient who has been previously treated, even they are showing good response with PFS up to 11 to 12 months and OS reaching up to 2 years. So what percentage come with intracranial mets? We have seen it is 18%, and it has even shown 80% intracranial response rate. Overall response rates in Asian patient is also very good, 64% with OS of 30 months. So what is your preferred MET exon? Both are there, Capma and tepotinib. Either can be preferred. Both have good intracranial efficacy. Tepotinib and capmatinib are equivalent with more brain penetration seen in tepotinib. Though the doses differ, in capmatinib it is 400 mg BD, and in tepotinib it is 450 mg 100, as I have already explained. And the dose modification is one-step dose reduction in both of them. So what are the most common side effects? Edema is the most common side effect, with grade 3, grade 4 reaching up to 8 to 9%. Rest is the frequency is low. Some amount of LFT derangement is there. How do you manage edema? So edema is a class effect. We can educate the patient upfront regarding this. We can promote lymphatic massage and also use diuretic as and when required. Also, we can measure the body weight and the limb circumference and inspect the lymph and in follow-up regarding the edema. And then according to the grades, we can either interrupt and reduce the dose. So why it is preferred? It is now recommended by NCCN. We have a prospective trial. We have a very good data showing good efficacy, good progression-free survival, OS, and good brain penetration to a tune of 88%. These are some case studies which I won't go into detail, but we can see the scans and we can compare it, that there is a good response rate. There's a complete resolution in post-treatment scan, which we would have not seen if we would have not gone by a driver mutation. This is the edema, which can be treated symptomatically. So in a conclusion, tepotinib, useful in MET exon 14 skipping mutation. Either patient has been previously exposed to therapy or it is treatment naive. It works in both with a response rate of 68% in naive. And the patient who has been previously exposed to treatment either in first or second line, the response rate reaches up to 40%. The class effect is pedal edema that can be well managed. It's a safe and effective first line therapy. Thank you all.
Thank you, Dr. Pooja. And is there any personal experience that you have used this drug, and
what was the methodology of detecting the mutation? Yeah, please.
Actually, sir, I have given crizotinib and it was detected on tissue biopsy only on the DNA-based NGS. I have yet not used capmatinib or tepotinib for MET exon 14 skipping mutation.
Thank you once again. So that was very comprehensive. And with this, it brings the end to the current meeting. And I would like to thank over here all the my co-conveners, Dr. Durgatosh, Dr. Munshi, and Dr. Shubham. And thanks to the technical organizing team, Mr. Tarun and his team, Garima in particular, and Ankit. And of course, thanks to the academic partners, Roche, Merck, and AstraZeneca. So with this, I would say a good night and thank you for joining us.
Thank you, sir. Thank you so much.